annual academic research symposium held by Avalon University School of Medicine. I'm Sarah, and I'm one student here at Avalon.
And I'm Hassan, also we will be your host for today's event. So the ultimate objective of research in medicine is to improve human health. It is not only to discover new therapies, diagnostic and prophylactic methods, but also to refine and scrutinize the available methods and make them more suitable for human use. With research, we're able to generate scientific evidence for health intervention, determine the effectiveness of health interventions, contribute to novel breakthroughs in medicine, and make life easy for health professionals, patients, and even healthy individuals.
With the onset of the COVID-19 pandemic, epidemiologists all around the world began to conduct research on the origins and development of the virus. These researchers managed to describe the symptoms, signs, and outcomes of a variety of variants around various population spectra. The mode of transmission and the causal agents were diligently determined, thus making it easy to set up projective measures. Not only did this research go deeper to identify patterns in susceptibility and complications, but it also determined the relationship between various variants of the virus and the transmissibility, morbidity, and mortality.
So along with all the challenges that the COVID-19 pandemic presented, it also served as a reminder that one of humanity's strongest defenses against dangers is collaboration through research. So the outlook of the future of medicine could be far more positive if we apply the same collaborative work in science to education, particularly in medical education. In the words of Malcolm X, education is the passport to the future, for tomorrow belongs to those who will prepare for it today.
We would now like to invite Dr. Lambo onto the stage to share a few words before we begin.
Good morning, everyone. Good morning. The faculty of Avalon University School of Medicine, my respect deans, the Naja in Bala, in Reshma, and in all of the things that are at our clinical sites in the United States. And though our chancellor is not here, that of course, we greet him and the president of our university, staff, and students. I think the students have said everything. I just wanted to leave three things last time for you today. We know very well that research is one of the three pillars of academic medical establishments. One of them research, education, and service to the community. And husband and Sarah have actually emphasized the importance of research. I'd like to tell you that COVID-19 has actually impacted the physics of our life in many different ways, and also has actually changed the way we deliver medical education and teaching pedagogy and research as well. Avalon is gifted with a lot of students who have come in, some of them have practical education. And you see, it's a very collaborative environment. One of those things that I tell students is that, to be to do a successful research and make an impact. There are three things that I like to really teach students. Access is number one. We have said that you are bringing to medical school, right? And also the assets that you have in the medical school faculty, you can turn to. And then the quality of the work. I would say my students that the work will always follow. You try to do good work, right? And the relevance of your work. And we see those things today, right? As our students and faculty, one of those things is always a joy for me when I see our students do very well, right in my house. And maybe some 5-10 years later, you will see that we can produce good quality. We get a very small medical school. So I just doing fantastic work in medical education. Today we will hear about surveillance of COVID-19 in Coruscant, right? Which is going to give a place of health these things you can learn, you will go through it in your life. You ask questions, you must have a question. You know, if you want to do a successful research, apart from the research methods, you need to know how to ask a clinically focused question. Right? And this, you need to have these habits as you go to the class, prepare for your class, and need to ask questions, and today you will see that even our students are doing very great, presentation today. You will see some of them, they can be for seminar review that are worth publishing, they're going to be talking about things. We also have students who have come with Masters of Science in universities and will be presenting their work on healing and adolescent health. And one of my joys is that the current work that I'm doing with my students, that homosexual partners and early initiation of sexual intercourse and contraceptive use, we were able to do a cross-section study, even encouraging to use cross data. That way I want to give back to us as well. So without more time, I welcome you to the 2022 Upper University Symposium. Thank you very much.
Thank you, Dr. Lambo. To begin today's symposium, we would like to introduce our first keynote speaker, Dr. Satish Arjun. Dr. Arjun graduated from Windsor Medical College in 2002. His passion for medical education motivated him to complete a master's degree in health professional education at the Baylor Center for Medical Education at Taylor University. He has also graduated with a Master of Sciences in Public Health. From there, he received the Principal Fellowship from the Higher Education Academy Advanced in the UK, which just comes to show his active commitment to supporting all dimensions of medical education. He has also completed a fellowship from the International Association of Medical Education in Europe, along with the CAAM-HP Fellowship from the Academy of Medical Educators in the UK.
Dr. Arjun has also finished the fellowship program from the International Association of Medical Science Accredited. He has also co-authored 8 textbooks and has a peer reviewer for numerous medical education journals. As the Dean of Avalon University School of Medicine, he is leading the development of educational programs by driving the Quality Assurance Committee and Self-Study Committee. He plays a significant role in the university's strategic planning, quality assurance, and quality control activities. Today, we will be discussing medical education during COVID-19. So without further ado, we would like to call Dr. Arjun up to the stage.
Good morning, everyone. Welcome to annual Symposium Avalon School of Medicine 2022. And I would like to thank the research committee and the committee members for putting up a great show here to meet all of us together. And maybe all of you know the history of Avalon Symposium. We started conducting this symposium in 2017. We were able to conduct till 2019. But what happened in 2020, I think all of you know about it, because of what we call the circumstances, we have to halt it for a couple of years. And we were not able to conduct this symposium for 2020, but in 2021. And we thought maybe this is the right time for us to start this symposium again. I would like to take this opportunity to thank the research committee, faculty members, staff, administration, and students who worked hard on this symposium. Thank you so much for all of you. And also, before I start my presentation for today, I think we never met after the ACCM accreditation decision, right? That we got. We never met in this auditorium. Definitely, we should take this time for all of us to congratulate all of us. Thank you so much for all of you again, once again, for the wonderful achievements that we made and we are only few medical schools in the Caribbean. I think that there are only 7 medical schools in the Caribbean who are full accreditation. We are one among them in the Caribbean. And also, we are the only one medical school in the Caribbean who are accredited by both ACCM and CAAM-HP. And I'm sure you must be proud of what you are doing. Thank you so much for all faculty and students. Well, good morning again. This is my small introduction. Thank you so much for the both Master of Science to say some nice words about me. But I just would like to give a small introduction of me also. And I think all of you know me as the Dean of the School of Medicine and also Professor of Clinical Skills. But apart from that, I do different things. One of the things that I enjoy the most is being the chair of medical education unit. And I think all of you know that there are 6 departments on the basic sciences. I think you know that there is human structure and function department, this is immunity and paramedics, maybe molecular based medicine, you know all those departments, but there is also another department on the basic science campus is medical education unit. It's not just, I'm saying it because I'm the chair of the unit, but we have done quite a tremendous job in the last, I can say last 2-3 years. And the other one of my role as chair of the quality assurance committee, I think even the master mentioned about my role as chair of quality assurance committee, we control, quality assurance and quality improvement. Especially one of the things that accreditation bodies were very much impressed with the culture that we call culture of collaborative, what we call quality improvement. That is one of the things which they like so much, and we are very proud as a quality assurance committee members. And also I am working as a board of directors for International Association of Medical Science Educators and a CAAM-HP site reviewer. Recently I joined as a reviewer for CAAM-HP accreditation team. And also I am working as president for accreditation agency of Curacao. This is a local accreditation agency which is located in Curacao. And I am working for them also as the president of accreditation agency of Curacao. Okay, so if you look at this, the triple aim, this is the triple aim. What do you mean by triple aim? If you conduct medical education, not just medical education, any healthcare professional education, and if you do it, and if you do any quality improvement activities or quality assurance activities, the 3 things that we look at, we call it as triple aim. What are the triple aims is what we call one of that is better patient experience. Whatever you do quality improvement activity in the healthcare, especially when you go to the hospital, and you are working as a physician, and quality improvement is one of the duty and responsibility of any physician that nowadays for working. So what is the role of this quality improvement? What is the aim for it is better patient experience definitely. And improving the public health, not just what we call 1 patient and 2 patients, but we should look at the quality of the public health. Community health is also very important for us, and the cost effectiveness. But to add to this triple aim, that recently we added, we call it as quadruple aim. What is the meaning of quadruple aim? The well-being of healthcare professionals. I think all of you know that what happened to the healthcare professionals during the pandemic. So many things happened to the healthcare professionals, and they were burnout, stress, and so that's why this what we call well-being of healthcare professionals also became one of the important criteria for quality improvement programs. So I would like to give a small introduction of what we call medical education, what we are doing here. And we published 3 publications in the last 1 year, which are very important publications. One of them is impact of accreditation on career in medical schools process. What happened to the career in medical schools process because of the accreditation requirement? I think all of you know about the ACCM requirement that they need all the graduates coming from medical schools, coming from an accredited medical school. And what happening to the career medical schools process because of this accreditation requirement? We published 1 paper. I think you can see there are 2 students involved in this paper. One is Chala Krishna and the other one is Manoj Kumar. I think both of them published this paper last year. Both of them are in residency this year, which is very good to see all of us. But not only that, but we all 6 others were very much delighted when we received a special note from the president of World Federation of Medical Education saying that this is one of his favorite articles on accreditation. We were very much proud to produce this paper, and this was published in Canadian Medical Education Journal. Okay, the other one that we 2 papers that we published is emergency remote teaching in the first 2 years of medical school during the COVID-19 pandemic survival. This is 1 paper we published this year only. And the other one that we published, and you can see that there are 2 students involved in this paper. Those are students who are in the clinical rotations, 2 students who are involved in this paper. And the other one that we published last year is special education during COVID-19 response at one medical school. And my today's topic is based on these 2 papers. You know what we have done to the medical education during COVID-19 at the Avalon University School of Medicine. So if we look at this medical education unit that we have on campus, we have 4 faculty members from this unit. One is myself, another one is Bala, and Praveen, and Navasu. These are the 4 members of medical education unit. And we started elective rotation also for clinical rotation students for medical education. Students can do elective rotation in this, what we call in this one. And then the last year we completed, I think 25 students did this elective. And this year already we have 15 students completing this elective medical education. I think all of you can think of what you call this medical education unit, elective in future when you are doing clinical rotations. And see, if you look at this one, so what happened during COVID-19? We know that there was social distancing involved. And not only social distancing, but the campuses were closed. Because the campuses were closed and social distancing, and we have to convert this face-to-face teaching to online teaching. So we converted this face-to-face teaching to online teaching. Not just for the basic sciences, in some medical schools, even the clinical education also was converted to online teaching. But what we have learned from the previous pandemics, are there any pandemics which happened in the past, and did they affect any of our medical education units and all those things? If you look at the severe acute respiratory syndrome, SARS during that time, Chinese medical schools, they have what you call, they have cancelled the bedside teaching. There is no more bedside teaching, no, there was no clinical rotations involved during the SARS time in the Chinese medical school. Not only that, they delayed the examinations also during that time. Another thing that what they did is PGL sessions were completely conducted online. I think all of you know about the PGL sessions. These PGL sessions were conducted online during the SARS time even in Chinese medical schools. And if you look at Canadian medical schools during the SARS time, they have what you call didn't allow medical students to the hospital. That is one of the things what Canadian medical schools did during the SARS time. Another pandemic which happened was what you call Middle Eastern respiratory syndrome. During that time, they identified three things, three key principles they identified during this much time. Instant termination of clinical rotations, they terminated all the clinical rotations during that time, and coherent decision making on university closure, there were closure of universities, and use of information technology, they used IT technology, and constant communication with hospitals and open communication with faculty, students, and staff. I think we must understand these three key principles will be applicable to any pandemic. We did the same thing during the COVID-19 pandemic also. There were closure of campuses, cancelled what you call, some of the rotations were what you call converted to online, but within 2-3 months, the rotations were back to normal. But for 2-3 months, some of the rotations had to be conducted online. And use of information technology, I think all of you must understand how this information technology was useful during the pandemic. So these three principles can be applicable to any pandemic for medical education. Not just for medical education, even for running an organization, running an institution, it's very important to have that consistent and transparent communication. That's what we did during COVID-19 pandemic also, that we have communicated with our students through the emails and through the news bulletins all the time. That was very helpful to us. And so during COVID-19 pandemic, we converted the online, we converted the face-to-face teaching to online teaching for basic sciences. So what we did is, for didactic lectures, we converted face-to-face to what we call Google Classroom and Google Meet. And I think most of the students, some of the students at least, you might have experience with what we call didactic lectures through the Google Meet. And a small group discussions were also conducted online using this Google Classroom platform or Google Meet. And especially small group discussions like what we call PBL sessions were conducted. And we try to give hands-on experience as much as possible. It's not easy to give hands-on experience online, same like on-campus teaching. So we try to give what we call hands-on experience, same as what we call on-campus teaching. Anatomy, they have used grants dissect videos. For histology also they use virtual microscopy using short-term videos. For pathology, I'm sure you know about digital pathology, they were using for virtual microscopy. For clinical skills, we used telehealth concepts. What is the meaning of telehealth concepts? We were using standardized patients in the classroom, and they were interacting with the students through what we call a Google Meet platform. We call it as telehealth concepts, and we used the same concepts developed by Academy of Communication in Healthcare. They are the ones who gave those principles, how to conduct these telehealth concepts. We were using that. And assessments were also conducted online. I think all of you know about it. In case the students who have done a pre-med program with us, you have experienced online assessments during that time. We were conducting assessments online. The students are required to use 2 devices. One device for what you call taking the exam, and another device for what you call video monitoring. And not only just for the internal assessments, even the NDME comprehensive basic science examinations were given online. But CBSE exams were given online only for a few months. I think within 6 months, we came back to normal. We were giving the comprehensive basic science exams at the prometric test centers or on campus. So it was just for a couple of months, I can say that. And feedback was given to the students. I think this is one of the key for the success of online teaching during the COVID-19 at Avalon University School of Medicine, giving feedback to the students. And faculty were conducting what you call feedback sessions with the students, Google Meet, and they were scheduling the appointment with the students and they were meeting with the students. That is definitely one of the key for the success of online education for us. And peer tutoring was continued. Even the peer tutoring, I was surprised to see the student enthusiasm and zeal to conduct this peer tutoring also online during the pandemic. And the clinical self-examinations, I think all of you know that clinical workshop examinations were conducted. Still today, we are doing the clinical self-examinations online, video-based programming. We are the same thing. The students will use two devices, one device for taking exam and another device for what you call video monitoring. Still, we are doing it. Tele-ASCIIs were conducted, ASCII examination, objective structured clinical examinations conducted online. We call it as tele-ASCIIs. And the one thing that very good thing about Avalon is disaster management committee. They are the ones who assisted the faculty and students during the pandemic, and they helped with what you call whatever the assistance is required. So definitely we should thank the disaster management committee who managed very well during the pandemic. The other one is, as I mentioned to you earlier before, the most important principle is consistent and transparent communication between administration and students and faculty members. That was the key for us to manage this. At least we were able to manage all the teachings and assessments during the pandemic time. And okay, we conducted online teaching. So how should we evaluate it? We conducted study. It took for us like 6 months for us to conduct this study. Not only just conduct the study, to publish for this study for us, it took for us 1 year. So almost we worked on this for 1.5 years. And we collected all the quantitative data and qualitative data required for this study. So we compared what you call the data that we collected between on-campus teaching and online teaching. So we collected both quantitative data and qualitative data. For on-campus teaching, we used the semester September 2019 because I think all of you know that September 2019 we were on campus. And for online teaching, we used the data from May 2020 because May 2020 complete semester was online. So we used that data for quantitative purpose. And for qualitative purpose, we interviewed the students and faculty members. Interviews of students, we interviewed almost 10 students. And 2 students were taken from each semester randomly. 2 students from MD1, 2 students from MD2, like that we took 10 students from 5 semesters. And we invited all the 12 faculty members. Except me, we invited all the 12 faculty members to participate in the interview process, but we were able to get only 9 faculty members. Total 20 interviews were conducted. So 10 plus 9, 19 interviews were conducted. It's a huge data as far as the qualitative data is concerned. If you were doing some 15 to 20 interviews, the qualitative data, that's more than enough. Because at least we can say that we were not able to get any further new information after conducting the 19 interviews. So I must say that it's very good data for us. And as far as the ethical consideration is taken, we have taken the approval from the Research and Ethics Committee of Avalon University School of Medicine. Informed consent was taken from the students, and informed consent was taken from the faculty members also. They have to give all the informed consent. We inform the students and faculty why we are doing this research, what is the purpose of this research, what are the benefits, and if there are any harms involved in it, we should let them know. So any students and faculty members, if they want to withdraw the interview study, they can do it voluntarily. And the interviews are conducted by student authors. Faculty didn't do the interviews because we thought that it's a bias if the faculty conduct the interviews. So we asked the students to conduct the interviews. The students were able to conduct the interviews. And as a principal investigator, myself, I trained the both students to conduct the interviews. And the results, you can see the results here. I'm not going to repeat all the results, but at least you can look at it. But most of the results that you see that we got the response rate, course evaluation. We look at the course evaluation. I think all of you know that you are going to fill the course evaluation at the end of the course module. We call it as end of course evaluation. All the students fill it out. So we took the course evaluation for the September 2019 semester and May 2020 semester. And if you see this, what you call the response rate for mind-brain behavior, for September 2019 is 73%, and for May 2020 is around 85%. For DAT1, you can see that the response rate for what you call September 2019 82%, and for May 10 out of 14, which is 71%. And the response rate to human structure, function, and 1 and 2, you can see there for both semesters. And even the same thing with the human structure, structure and function 2 also. And we have gathered the data even for clinical skills 1 and 2. We have taken the course evaluations for clinical skills 1 and 2 also. And for clinical skills 2, you can see 100%, for clinical skills 1, 80 and 89.4%. That is the response rate from the students. But any response rate between 50 to 70%, which is a good response rate, and we got a good response rate. So once we got the course evaluations, and we took the values of mean and standard deviation, we compared between September 2019 and May 2020. So we looked at what you call mean and standard deviation. And once we have the mean and standard deviations, then we calculated what you call p-value with the help of what you call t-test. The reason why we use t-test is all the course evaluations were normally distributed and homogeneous variance. So we use the t-test. And there was no statistical significant difference between course evaluations of September 2019 and May 2020. We didn't find any significant difference. If there is any significant difference, the course evaluations were better in May 2020 with online teaching compared to on-campus teaching. So that's why we found that the students are happy. And the course evaluations that we looked at, these are the questions, or the 16 questions, what we look at the course evaluations. I think most of the students, you know that the course evaluations have almost 30 to 35 questions. But we didn't take all the questions, but we took only the 16 questions which are relevant. We looked at the quality of the teaching of the what we call subject, the assessments, feedback, students what we call feeling of achieving the outcomes, or maybe students' involvement in the classroom activities. These are the questions, and we looked at only those what we call mean and standard deviation, and there was no statistical significant difference. But even if there is, it was much better for what we call for online teaching. The next slide, and this is also a reference slide, and it's very important for us because we look at even the students' performance on assessments, and we compare what we call students' performance on assessments compared to what we call the same semester, September 2019 and May 2020. And there was no statistical significant difference except for 2 courses. Those 2 courses were mind-brain behavior and clinical skills 2. Those are the only 2 courses which have a statistical significant difference for the students, which we call assessments. Students' performance on assessments, because we have taken our grades, the students' grades, and we calculate the class average value, and then we looked at what we call statistical significant difference for the mean values. And we couldn't find except for 2 courses. But these 2 courses were better on campus teaching, I can say that. But at least, one thing I would like to tell you that most of the courses we were able to manage with online teaching, but except for a couple of courses like anatomy and clinical skills, these are the courses which require a lot of hands-on experience, especially students being on campus. And as I mentioned to you, we also gathered the interviews from the students and faculty regarding the perceptions of online teaching. So we collected all these interviews, and all the interviews were recorded. And we used the ACCM software to transcribe these audios. And then we analyzed the data. From those texts, we analyzed the data. We use the thematic analysis. There are so many what we call ways of analyzing the qualitative data, grounded theory, phenomenological, what we call data analysis. Like that, there are so many ways of what we call analyzing the qualitative data, but we use the thematic analysis. And we found certain themes in the qualitative interviews. One of the themes is what we call earlier experience with online teaching and learning. It's very interesting to know that most of the students and faculty members that we interview, they have no previous experience of online teaching or learning. They don't have any previous experience. And most of them said, what we call 1 or 2 faculty members said that they have done some online courses, but they have never done online teaching. But still, we were able to conduct what we call online teaching for almost a couple of years, or at least we can say 1.5 years. The reason is we have done quite what we call training to the faculty members and also students with the help of IT department and faculty development activities were conducted. And when we looked at the simulators for this emergency online teaching, we call it as emergency online teaching because this change process was not a normal change process. This change process was what we call unexpected change process. The reason is because of the pandemic, we have to convert what we call on-campus to online teaching. That's why we call it as emergency remote teaching. And the simulators for this, definitely pandemic is a simulator for this change. Otherwise, we wouldn't be going to online teaching. And at the same time, a lot of students and faculty members mentioned, at least students mentioned that this online teaching was helpful in saving time. I will tell you what is the reason why they said it in the next slide. And if you look at the obstacles for emergency online teaching, one of the obstacles was what you call technological difficulties. Of course, there will be some technological difficulties with the internet and cloud issues and all those things. But apart from that, there was what you call quite enormous positive experience for what you call for students and faculty members. And if you look at the what you call advantages, convenience and flexibility, this is the most what you call thing that most of the students and faculty members mentioned: convenience and flexibility. Not only that, even faculty members who are giving the recorded lectures, the students can go back and watch the recorded videos. That's what we call it as flexibility. There was flexibility for the students and saving time and other benefits. You can see the quote from one of the students, what he said here. When I have the school, I have to get up and I have to get ready to go to the school. But now I don't need to get ready and I don't need to go to the school. I can save the traveling time and I can use that for creative assignment. So that is one of the quote that came from the students, that it can save time for them if there was online teaching. And the other, if you look at the disadvantage, limited hands-on experience and personal interaction. So this is definitely obvious that with the online teaching, there will be always limitations for hands-on experience, or also limitations for personal interactions, especially personal interactions. These personal interactions are very crucial. The personal interactions between students and faculty and personal interactions between student and student. That's very important because this is a kind of motivation for the students. Because when they interact with other students who are doing well, definitely, it's a kind of motivation for all of us so that all the students will do much better. So you can see here, lack of motivation is also one of the what you call obstacles definitely for online teaching. So what are our future implications? What we learned from this study, or what we learned from this emergency remote teaching? We recommend adapting interactive remote learning lectures using highly sophisticated technologies and virtual clinical case-based discussion. If anybody wants to go for online teaching, this is something that what we need to do, that we need to adapt very sophisticated technologies and we should use what we call clinical case-based discussions. To be successful, if learning objectives, teaching methods, assessments are in alignment. That's what we call it as constructive alignment or base construction. Of course, it is the same thing with on-campus teaching also. So when you are doing the teaching, if the teaching needs to be successful, if the education needs to be successful, the learning objectives, teaching methods, we call pedagogy and assessment should be in the constructive alignment. And student satisfaction with feedback. This is one of the things that we learned from the pandemic, that what we call when you give the feedback to the students within the time frame, not like after 1 month or 2 months, if you are giving feedback to the students, that may not be useful to the students. If you give feedback to the students immediately within the time frame, within at least what you call the required amount of time, then it's more useful for the students. That's also one thing. When we look at this, what we call the sample size, is definitely for quantitative data, sample size is small. So because the sample size is small, we cannot generalize the findings what we have done. So that's one thing I would like to mention as limitations to our study. It requires further research with longitudinal data across institutions. What we recommend is for many institutions to conduct the data across the institution at various what we call at various time points. What we call as longitudinal data should be collected. And then the institution can consider direct lectures. But I think maybe some of you might know that some schools are already what we call direct lecture free. That means they don't conduct any direct lectures, but they give the recorded videos and the students can watch at their own convenience. But that can be effective, especially if the students are actively what you call engaged in other kind of classroom activities. So what do you mean by other kind of classroom? Even if you give direct lectures online, you should do the group activities, lab experiences, and clinicals should be done on campus. And remote education in the first years of medical school can succeed if students and faculty are appropriately engaged and actively involved in class activity. This is the key. If you want to conduct online teaching, the students and faculty should be actively engaged in the classroom activities. Not just teaching, but suppose, for example, if you're doing online teaching and you call the same students for 5 times, they don't respond. then that is not what we call active engagement in the class. But when the students and faculty are actively engaged in the class, that online teaching could be more successful. The key for either on-campus teaching or off-campus teaching or online teaching, the key is simple. Provide structure to the classroom activities, give students time, and provide feedback to students to make online education or on-campus education always successful. So you have to have structured classroom activities. So it's not just speaking all the time in the classroom, but we should give what we call some kind of time for the classroom activity, either group discussions or hands-on experience or whatever it is, or maybe even problem-based learning activities. There should be what we call engagement in the classroom activity, and should be given time to the students to adjust to the learning environment, and definitely feedback. Feedback is the key, and we should not hesitate as a medical educator. We should not hesitate to give feedback to the students, whether it is positive feedback or negative feedback. Thank you so much, and this is for today. Thank you.
Thank you so much.
Great, thank you, Dr. Arja. Our next keynote speaker is Dr. Jagdish Chandra. Dr. Chandra is a former professor and head of the Department of Microbiology at Government Medical College in Chandigarh, India. Of 2020, after spending nearly 3 decades with this institute, and is presently the in-charge consultant at a fungal clinic in Panchkula, Haryana.
Dr. Chandra's fields of interest mainly surround medical mycology, hospital infection control, and HIV. He is the author of a textbook of medical mycology and has around 205 research papers published in national and international journals. He previously taught at the University of Manchester as a visiting professor 2008 to 2009 in the field of medical mycology. Today, Dr. Chandra will be presenting his work on post-COVID-19 mucormycosis. Please give him a warm welcome.
Okay. Good morning to all. I am presenting with post-COVID mucormycosis. First of all, I am thankful to the organizer that they have invited me to this academic feast and as deliberations on a very current topic, that is mucormycosis. During the last days of 2019, the SARS-CoV-2, that is COVID-19, emerged from China, maybe in coordination with US, and it came in so many waves, like first, second, third wave. But during second wave, India became very prominent, and there were so many secondary infections to COVID-19, and one of them was mucormycosis, that is COVID-associated mucormycosis, or CAAM. During that period, so many names were given to this disease as black fungus or similar type of fungal disease as white or yellow fungi, etc. I want to highlight, by the way, this is one of the point where this book written by me became viral during that time throughout the world because of one line just above the historical perspective. I will zoom it like this one. This is 4th edition of 2018, that mucormycosis is going to destroy India shortly in a couple of years. So this prediction came to be true during this COVID-19. Now the big question is that why there was upsurge of mucormycosis cases in COVID-19 pandemic. So many risk factors have been contemplated. However, in most of them, evidence is required. Particularly, the first blame went to injudicious use of steroids just to avert the complications like cytokine storm. Other things like contaminated masks without changing, they were found to be contaminated, or the contaminated accessories like oxygen, humidifiers, simple water was used, sterile water or distilled water. role of medical oxygen because it was depleted and industrial oxygen was used, particularly in our country. And that may be one of the reasons, frequent steam inhalation, etc., leading to trauma and entry of the fungus or some of the metals, particularly iron and zinc. This was the Delta strain during that outbreak mainly. And in this case, it was targeting the islet of Langerhans of the pancreas through angiotensin converting enzyme, ACE2 receptors. This was the most important factor which was not highlighted in the mainstream media because of the reasons for the upsurge of the cases. And in some of the studies now it is coming recently in March 2022 that oxygen use was not that reason because in those in 86% of cases oxygen was not used. That means that may not be a precipitating factor. Or in some of the patients even steroids was not used. Still they presented with the mucormycosis. So it goes with the finding that it may be AC2 receptors. Leading to the mucormycosis cases. Other things are also coming now, particularly the cow dung, etc. This paper came in recent times. That this may be one of the reasons. So mucormycosis versus black fungus. This is misnomer to call it as black fungus because Dimetices fungi, particularly Alternaria, Corvularia, etc., they have melanin in their cell wall. That is why they are called as black fungus. Mucormycetes, they don't have melanin and they cannot be called technically as black fungi, like in Tinea nigra, chromoblastomycosis, phaeohyphomycosis, etc. So technically it is wrong to call as black fungus, but in media it is very popular and people understand when you label it as a black fungus. It became a notifiable disease in India since very beginning, and most of the time the diseases are not notified, but this was one of the fungal disease which was notified under the IDSP project. And rest of all the medical organizations related to fungal or in general in India and outside India, international level, ISHAM, WHO, etc., they came out with guidelines that this has to be done, this has not to be done during the handling of the patients of mucormycosis. Mucormycosis is a rapidly destructive necrotizing fungal infection, usually found in diabetics. It occurs because of the disruption of the continuity of the mucosa or skin or any other site. Or systemic risk factors, particularly hyperglycemia is the most important, particularly going towards the ketoacidosis. In Western countries, it is the malignancy, leukopenia, etc. They are most important, but in Eastern side or Southeast Asia, it is the mucormycosis is found mainly in the ketoacidosis, hyperglycemia patients. It is one of the upcoming disease, and about 51,000 cases were reported during that second wave in April, May, June 2021. These are just the gross incidence of these different types of mucormycosis. Particularly, it is rhino-orbital cerebral mucormycosis, which is constituting almost 50% of the cases. Rest of like pulmonary, cutaneous, gastrointestinal, or even isolated renal mucormycosis or disseminated, they are in total constituting about again 50%. Mucormycetes are now categorized under glomerulomycetes because earlier it was zygomycota and it is abandoned. Now it is mucoromycotina having mucormycosis. Acute invasive infection in immunocompromised patient, and its counterpart, another infection is there, that is chronic subcutaneous infection, immunocompetent patient, that is entomophthalmycosis. These are two clinical entities, sometimes confusing to each other, but they are very different in presentation and their outcome. These are different species of mucorales. Mainly it was the Rhizopus arigus which was encountered by us, and rest of the species were rarely encountered, but definitely they were there. Apophysomyces, Xenia, or other rhizopus species, Syncyplastrum, etc. In Entomophthalmicrotina, it is Conidiobolus and Basidiolus as a passing reference because sometimes they also confuse the euchorales with, but they are from different group. These were the lesions typical, like below the left eye, there is a scar type of lesion. And by just looking on the patient, nobody can think of that it may be a mucormycosis patient. When you investigate, it is found to be hyperglycemic or diabetic patient, young boy of about 24 years. And when you dissect this wound and see under KOS, it is found to be having non-septate right angle branching, typical of mucormycosis. Like this one, they are again affecting the eyeball, leading to restricted movement and the visibility, etc. Rhino-orbital, both the orbits, they are involved in deep-seated mucormycosis cases. If like in this case, the sinus is involved. One sinus is totally blocked, maxillary sinus. So most of the cases were of rhino-orbital and rhino-orbitocerebral mucormycosis, but some of the cases were of pulmonary mucormycosis. Definitely, we encountered this thing. Like most of the time, we see halo sign in case of aspergillosis. The marks area, and in this case also you can make out the same thing, halo sign found in invasive aspergillosis. But in case of mucormycosis, it is other way around. It is reverse halo sign where the central area is resolved and the periphery is prominent. So this is a typical sign of reverse halo signs of mucormycosis in pulmonary mucormycosis. This we saw in during this the outbreak. Just more enlarged view. And another type of presentation was there that the hilar area was prominent and very during very short time there was formation of a cavity, very big cavity. Instead of reverse halo sign, big cavitatory lesions were there, and in a very short duration, because the underlying COVID-19 was the progressively accelerating the disease. Some of the patients were of cutaneous mucormycosis. I have taken some of the photograph from these patients and some as a teaching exercise also from the earlier collections. In this case, it is typical lateral abdominal wall mucormycosis, typical necrotizing lesions of extensive areas. If you just see more deeper areas, it is full of mucorales, particularly like this blackening of the wounds, advanced lesion. After debridement of gluteal areas, this is from the shoulder area. These are classical patients presented in India. And on gross examination of the patient, you can make out that one of the differential diagnoses is mucormycosis, cutaneous mucormycosis, like this type of lesions, extensive lesions. This type of lesions. So many patients are there of this type of lesions of different gluteal areas, shoulder area, involvement of these things. Like in this case also, it is the same repetition of the so many patients we have seen. And one of the container, by the way, it was having apophysomasis, variabilis. Without adding anything, after 24 to 48 hours, it was full of mucorales. And this white cottony growth is found in apophysomasis species as well as succinia species. They are diagnostic if the growth is coming like this one. Isolated renal mucormycosis patients are also there with fever, flank pain, and hematuria, anuria, and pyruria. This is typical presentation in India and China, that where the patient is presenting with flank pain, then it turned out to be renal mucormycosis. Very unique finding. Isolated, other lesions may not be there anywhere in the body, but renal mucormycosis. Some of the patients were having disseminated mucormycosis, also involving the extensive chest cavity, both the cavities. Some of the patients were of gastrointestinal mucormycosis, we have seen involvement of the stomach. During post-COVID mucormycosis, we have observed some of the things like although the gravity of the patients is not that much, but still they were being presented. Uh, After the second wave was over, the patient came to the OPDs. Now there is recurrence of the cases who already got treated or healed. Now we have seen one feature that the second wave had gone. Now we are in third or fourth wave, which are relatively mild as compared to second wave, but still patients are coming. It is not that patients are not coming, still patients are coming. It is the recurrence of earlier treated patient or partially treated patient. So it is recurrence of mucormycosis after the second wave has gone. And now the involvement of the deeper areas, particularly bones, etc., that is very, very important of the maxillary area and other areas. The bony involvement is very important. Otherwise, bones, they are very less likely to be penetrated by the mucorales. In the laboratory, the diagnosis is not very difficult. You make the KOS finding, and it is a non-septate hyphae with right angle branching, whereas in Aspergillus, these are acute angle branching with narrow branching. It is contrast with Aspergillosis group of fungi and mucorale group of fungi. You can make out the diagnosis. You can use the calcofluor white also to highlight these right angle branching hyphae. We have seen one more thing during COVID-19, that we had mixed type of infections. That means mucor is present as well as Aspergillus is also present. In almost one third of the patients, total patients presented with us, almost one third were having mucor with Aspergillus or mucor with any other fungi. So in the same field, we have seen non-septate hyphae as well as septate hyphae. If you can appreciate in your slide, in your presentation there, so you can make out in single slide there is non-septate as well as septate hyphae. Mixed infection, one third of the patient presented with this. This is important because in that case, you will have to start the treatment covering aspergillosis as well as mucormycosis. These are histopathological findings with ribbon-like hyphae, again non-septate hyphae with right angle branching. You can go for Gomori, methinamine, silver stain also, black colored hyphae with the same finding of non-septate hyphae. This is one of the sections having mixed infection. Non-septate hyphae fungi are also there and septate fungi are also there. So I have already told that it is one third patient presenting with this mixed findings. This was a very substantial number in our hospital and throughout India. This is Rhizopus rhizosus. We can grow on simple subordextrose agar or SDM medium. It is not a fastidious fungus, but if you handle it with homogenizer, etc., then it may not grow. So you just put the sample as such on the tube or plate without grinding it. Rhizopus rhizosus, these are the different tubes. I mean, Rhizopus rhizosus. One more thing was that we got Homothelicus also. Rhizopus homothelicus, where the suspensor cell is only on the one side. You can make out it is very easily made on the LCB mount, because most of the time these sexual spores, they are not visible in mucorale. But in Homothelicus, Rhizopus homothelicus, it is very clearly visible, very frequently visible. We got this number, substantial number of Rhizopus homothelicus in addition to Rhizopus rhizosus. Rhizopus rhizosus, this is LCB finding. Microsporus also, where the spore size is small, sporangium size is small, and the conidiophore size is also small. All the three things, they are smaller than the Rhizopus rhizosus. That is why it is called as microsporus. Apophytomyces variabilis was also reported in some of the patients. It is typically LCB mount showing champagne type of appearance. This is champagne type of appearance, champagne glass type of appearance. Apophytomyces variabilis. Earlier it was Apophytomyces elegans in India, but now it is almost replaced elegans with variabilis. In almost all the patients of Apophytomyces, now it is variabilis species. Succinia is also reported vesiformis, and this may be reported, and commonest one is vesiformis. Like this is a classical textbook picture of Succinia vesiformis, a vast type of appearance. And earlier, before this COVID, we reported Arthrospora also, Succinia arthrospora, and Lotroporiformis also. These are from our institution. They are just before COVID-19, just incidental finding. We can go for antifungal susceptibility testing either by this UCOST method or CLSI method. Anything can be, any of these two methods can be adopted, but the resistance is not that much problem. The diagnosis and the early diagnosis is the main challenge for a microbiologist or a clinician. Serological diagnosis like precipitation reaction, galactomannan, beta D glucose, and PCR, etc., they are as not significant as far as COVID associated mucormycosis is concerned. We should not go for these tests. Like in aspergillosis, they may be important, but in this case, they are not at all important. The management is very simple. The first, the underlying things are to be depleted. Like if patient is having diabetes, it has to be corrected. If patient is on steroid, that has to be stopped. All the risk factors have to be stopped, and KOS, calcofluor, histopathology, etc., can be done. And we have 3 antifungal agents, particularly amphotericin B, maybe conventional, liposomal, or topical. Most of the time, liposomal is preferred. Then other 2 azole derivatives, posaconazole and isavuconazole. As such, azole derivatives are not given in mucormycosis except these 2 which are indicated. Hyperbaric oxygen may also be given sometimes. Mucormycosis is an increasingly emerging fungal infection with a formidable mortality, and particularly during the COVID-19, it upsurged to a very great extent. A thorough knowledge of high index of suspicion are important to make an early diagnosis and appropriate treatment. Physician and surgeon do not normally associate fungi with necrotizing infection. They think that it may be some bacterial infection. They start with antibacterial regime. Well, these necrotizing infections, they entailing in delay in diagnosis and rapid progression of the underlying infection, and which may lead to irreversible level of the patient. There is a need to awareness among the clinician, because clinician, they are not aware about these aspects, so that they can have high index of suspicion to establish appropriate diagnosis at early stage of the fungal disease, so that specific treatment can be instituted well in time. Cooperation and live communication among the clinical specialties and microbiologists is must to reach the final diagnosis and effective therapeutic modalities. Blood sugar is to be restored to normal level as early as possible, because most of these patients, they are having underlying diabetes mellitus. Once suspected diagnosis is not very difficult, thereby immediately treatment may be instituted in the form of surgical debridement and antifungal regime. In our hospital, we within half an hour we provide KOS wet mount, and within 2 hours we try to debride the patient, and patients are saved. Otherwise, they are bound to die. If you have lost one day, you have lost the patient also. Thank you very much. Any question I can take up? Survival is that if the patient comes in time at a very early stage, then the survival chances are maximum. If there is delay of 2 or 3 days, then it invades to the deeper tissues, and it is very difficult to save those patients. It is the time factor. The most important factor is time factor. In the early stage of the disease, we can establish the diagnosis and treat the patient.
Is there any residual of this case, like in the lungs for days, weeks, months, years?
Yes, yes. When the surgeon is operating, sometimes there is residual is left, and this present as a recurrence after some time. after 2 months, 3 months, 6 months. So this we have seen in the patients. Rather, that is the ideal post-COVID mucormycosis when something is left, maybe in a very minute amount, but that progresses to a full-fledged disease after a few months.
Any relation between the background exposure?
No, there is no specific exposure. Uh, this fungus is there in the atmosphere, and from anywhere they can take it.
Thank you, that's great.
Do you have any more questions? Okay. All right, thank you, Dr. Chandra. Let's give him a round of applause for presenting. So Dr. Kelly completed his medical studies in the Netherlands, and after working shortly as a family physician, he went on to supervise and coordinate the vaccine administration and campaigns combined with preventative mother and child health at the Public Health Department of Curaçao from 1986 to 1987. In the following years, he specialized in social medicine in the Netherlands, including certain courses taken at the Johns Hopkins School of Public Health. He then went on to work as a scientific co-worker, specializing in cardiovascular, nutritional, and infectious disease epidemiology, as well as biostatistical methodology in the Netherlands Institute of Public Health. He then completed his PhD in epidemiology in 1995.
Dr. Kelly returned to Curaçao in the following 27 years to work in the field of public health. His positions range from manager of staff group planning, managing epidemiology, and biostatistics in St. Elizabeth Hospital, to being the head of Curaçao Public Health Service. Additionally, he worked as a director of the Curaçao Health Sector and currently works as the Inspector General of Health in Curaçao. He has been teaching since 2007 in different academic institutions and has since published several articles on cardiovascular, nutrition, and infectious disease epidemiology. Today, he will be discussing the surveillance of COVID-19. Please welcome Avalon's very own Dr. Kenneth.
Yes, good morning. Welcome. It's good to see that, despite the fact that it's Saturday morning, we're only present, and certainly a round of applause. Everybody is wide waking up. So today we're going to talk about a little about COVID-19 surveillance, because this is quite shocking for us all. There is a saying that says what you cannot see cannot hurt you. But in this case, it's an example that what you cannot see can hurt you. So I'll take you first to the early beginnings of the pandemic, because one of the questions was in the beginning, how did this come to be? There were a lot of conspiracy theories ranging from 5G networks to bioterrorism. So the question is, what did happen? And also, what did happen actually in Curaçao? How was it managed in Curaçao? What did it mean from Curaçao? So first, how did COVID-19 start? Actually, it started like, in the first instance, like a poorly understand viral pneumonia. And at the end of the day, a novel coronavirus was isolated. We all know the story. It was first indicated by a Chinese ophthalmologist who later died from COVID himself. But he indicated that there was something there that was seen, that was never seen before. So that was December 2019, where the first cases were alarming due to admission to clinics. By January 2021, the WHO proclaimed a public health event of international concern. Actually, that's usually it's a pre-phase of a pandemic. And it took them a long time, a relatively long time, before WHO proclaimed a pandemic in 2020. We as epidemiologists usually we consider a pandemic when you have an epidemic going on with in-contact transmission in more than 2 countries, or in more than 2 continents at the same time. So basically, on that definition, actually there was a pandemic going on from January 2021. The information start was 2019, 2020, and the question was always, what did actually happen? How did this come to be that so suddenly there was a massive explosion of COVID-19? So the WHO instated a team of 34 experts, consisting of 17 international experts and 17 Chinese experts, actually, which committee had to investigate and to come to conclusions about the origins of COVID-19. So different possibilities were evaluated. Remember, the first one was that there was transmission from the Wuhan market. From there, where the virus sprung over from animals, infected animals, a zoonotic, to actually to humans, and from there it sparked over. Now, based on the investigation of this team, at the end of the day, it seems that most markets in Wuhan were infected and were the surfaces and materials were contaminated with COVID-19 at the same time, so with SARS-CoV-2 virus at the same time. So actually, that is not the beginning. Another pathway that was investigated was the possibility that it was introduced by contaminated food, because it was also shown to be present in contaminated, even in frozen food that was brought in Wuhan, and also other possibilities that the famous possibility of a leak from the Institute of Virology in Wuhan, where probably there might have been enhancement experiments going on for viruses for bioterrorism, and that somewhere there, and there was a leak with 5 co-workers, and then there was a specimen that was left outside instead of putting away in a BSL laboratory, so that from there, co-workers got actually infected, and then from there it spread. The theory is also the most unlikely theory. So the most probable theory right now considered is that at some stage there has been some crossing over from animals to humans, but the most probable is what has been shown is that COVID-19 had already been prevalent in Wuhan from the beginning of December at least, but had not shown such serious cases in order to get them hospitalized. And when the explosion came, it was huge because it was already there, and that's also why it could spread. Now the question is, okay, if it was there, how could it spread so quickly to the rest of the world? Now remember everything, and there is the question is, if you look at it, so the question is, and we'll see it later, if you have such an explosion, how could it happen? And we'll talk about it when we're talking about surveillance, the definition of surveillance. I will present you a little bit other wording, unconventional wording of surveillance in order to understand why this could come to happen. So this is the already known SARS coronavirus 2 structure, with very important, of course, the spike protein. Actually, there is the mechanism to enter cells. We see the spike protein bind to the ACE2 receptors, and thereby having entry to the cell. And when it enters the cell, we have the usual viral replication mechanisms leading to viral replication. The special thing is here, of course, the binding to the ACE receptors, especially ACE2 receptors, which also explains why some people are more susceptible to serious evolvement of COVID-19. We've seen the evolvement of COVID-19 different variants, and those variants all the time they had mutations, and most important mutations were the spike mutations in the spike protein. Here we see one example in the B117 And here is another one, also showing the spike protein. I'm not going to get into that because we're going to talk about surveillance. So the question is, what is surveillance? Actually, now surveillance, we know active and passive surveillance in the sense that in active surveillance, we actually actively gather the data from physicians, from public, from other sources that we have. While in passive surveillance, usually we wait for the data to come to us. Active surveillance gives more accurate data. The risk for unreporting is minimized. However, it takes more persons, more resources, more money, and more time to be realized. However, that is the most important type of surveillance that we have. So, but if you put word surveillance in an alternative word using other words, now the quality of surveillance will be that if you are going to look for something, first you must look for the right thing. And looking for the right disease and the right symptoms and signs of the disease, actually this implies that the total spectrum of the disease must be known. Disease, as known, a lot of diseases express themselves as a flu-like period, and after that, after a few days, the true disease is then being revealed. The other thing is that we must have adequate diagnostic tools in terms of sufficient sensitivity, specificity, positive predictive value, negative predictive value, in order to indeed find it if it is there and exclude it if it's not there. And we also must have adequate case definition. Now, what happened in COVID-19 is, since it was a new disease, it has also unusual presentations. In the beginning, we all thought, okay, this is a pneumonia, which is caused by coronavirus. But later on, the spectrum of presentation started with other symptoms, loss of smell, loss of taste, high temperature, and even rashes, dry mouth, headache. So the symptomatology actually was different, and also the percentage of asymptomatic presentations, that percentage was unknown. So based on this difficulty, the first cases probably were not even noticed because there were minor cases of COVID-19. And that's also the explanation why it would explode so rapidly in Wuhan and also in other parts of the world. In the end, the PCR was developed. It was able to lead to a very good diagnosis, but then again, the availability of PCR testing that came very slow to be, which took some time, so that a lot of cases could be left undiagnosed. Now, and then we have the adequate case definition. Here is something that also was not clear at the beginning, because usually we have the formulation of the case definitions to tie them to the first known cases, and here it went wrong, because the first case definition included that somebody needed to have symptoms and signs, but they needed to have a tie with somebody or the place of Wuhan. And this is where it went wrong, because while everybody was closing airports for people from Wuhan, from China, infected persons from Italy, from Germany, from Spain, could enter freely all countries. And while people were focusing on those symptoms in patients from Wuhan, other people with the same symptoms actually were overlooked. So when this came up, it was already clear. Remember the first words of President Trump in the United States: we have only 1 or 3 cases. We're going to contain this. We have this under control. But at the same time, later CDC admitted that the patients from Italy, UK, Spain, Germany, they were already in the country. So they are ready. And this happened not only in the United States, but also from in other countries, because there were also people from other countries who, that actually, went back to Wuhan and traveled hands and forth before it was discovered that they were having COVID-19. But then, the eco-surveillance, so that was a blind spot, even in eco-surveillance. And then we had a question about the adequate reporting. People were not sure whether China was reporting the right cases, in the right places, etc. But also in other countries, the reporting was an issue. Now, then the other part of surveillance is that you must look at the right places and right places and the right moments. This indicates actually the importance of the mode of transmission of COVID-19. In the beginning, it was thought that COVID-19 was transmitted by close contact, that it was actually a droplet infection. However, if we observe well, the Chinese know better, because if you have only a droplet transmission, you will not go around disinfecting the streets. Okay, so you will not go around handling areas considering aerosol transmission. And the thing of COVID is it was discovered quite late that COVID had a lot of modes of transmission. While people were focusing on the droplet transmission, also the surface contamination and the direct contact with surfaces was neglected. But later it was shown that in certain surfaces, the SARS-CoV-2 virus could stay intact and stable for up to 4 days. And this is quite dramatic, because in 4 days, a lot of things could happen. So, and it ranged from a number of hours, depending on the material, to 4 days. And 4 days is considerable. So also the right moment, when is the moment you should consider it? In earlier days, it was considered that the people experiencing symptoms and signs that then you had to handle. But then later on, it turned out that people that could transmit the SARS-CoV-2 virus up to 4 days before expressing symptoms and signs. So here also the difficulty comes, because if you don't have a clear view of possible transmission, and actually you have then a transmission mechanism that could go on without anybody noticing it. And this is without even mentioning the asymptomatic cases that were proved later to be able to transmit the disease. So there were a lot of issues here in the surveillance that could facilitate a rapid explosion with even the first cases of COVID-19. The other thing that also facilitated a huge explosion, that is the rate of mutation of the coronavirus. This is one of the highest rates of mutations we know with microorganisms. And in this case, if it's a very contagious one, and also giving a relatively short time, short duration of immunity, then you have the question of reinfection, but also when new mutants have the capability to show evasion of immunity so that your immunity is not sufficient, we have a ideal set of circumstances for a pandemic to expand and to continue active. And also the vaccination that came, that had to be evolved rapidly. We've never seen a vaccination program being wrapped up and finished in such a short time. Even there, we had difficulty that because the immunity was, not only immunity was invaded, also the effectiveness of the vaccination actually was affected. And the thing is, you might say yes, but at the end of the day, we had the idea of herd immunity by vaccinating large parts of the population. So that should block the transmission and bring the pandemic to an end. Now, the issue here is that if you look at the fundamental definition of herd immunity, that is that if you have sufficient immune persons, the virus circulation will be blocked. So people don't get a disease. If they get it in a mild version, and the virus circulation is blocked. Now, the thing is that after the first vaccination round, and we all Pfizer, Moderna, Oxford, etc., what happened is that the first variant of concern, that was the Delta version, the effect of vaccination was that you could prevent hospital deaths, you could prevent ICU admissions, you could prevent serious cases, but it would not block the virus circulation. And that problem started. Why? Because as long as you do not block the virus circulation, you cannot stop the mutation process. And with every mutation process continuing, you have two dangers. First danger is the increased contagiousness. The second danger is that the virus could become more pathogenic. And also you have the possibility of co-circulation of different viruses that could lead to recombinations in leading to a very unpredictable situation. So, and this is also the explanation why this pandemic is not over yet. Right now we are at a place that the BA.5 is the most contagious variant we've seen until now. We still have evasion of immunity. The immunity given by other variants does not prevent in COVID-19 with Omicron or especially BA.5. And the vaccination is still effective at prevention of serious cases, deaths, and ICU admissions, but not on prevention of contracting disease and also not blocking the propagation. We've seen the virus combinations in place, especially the Delta combination of Delta with Omicron. It did not progress onto big concerns, but the fact that the virus is there and keeps circulating means that this will happen in time. We've seen different variants of concerns, and this will be later reflected in the Curacao data, where you see that any variant of concern also leads to a spike in the Curacao data. We've seen the upper version, original one version. We've seen the Alpha version in the United Kingdom. We've seen the Benin in South Africa, and then we have seen the Brazil version, and then the Delta version from India. Here, you see where a biased approach from the scientific world can cause a lot of damage, because a lot of people thought that when in India the scientists warned of a new variant, the rest of the world were saying, oh, it's not just serious, it's just about India is highly, very close, densely populated. There you have more transmission probability. So that would be the cause of the different effect of Delta. But later, when Delta started spreading around the world, people had to admit that it was a more serious. And here in Curacao, you will see that Delta had an enormous impact. Here you see that the different variants of concerns. These are not the variants of interest, but only the variants of concerns where you see the most, the latest one, the current variants of concern, where the BA.5 is now the most serious one. One that is under investigation, that is BA.275, which is being watched, and it is also spreading, but it's not so predominant as the BA.5, which is most predominant in most countries. So this is about the beginnings and the origins. The global situation right now is that we have 562 million cases, 6 million deaths. Now, if you put it into perspective, actually, here we have COVID-19. This is data until May. Sorry, February. So you have to substitute this for 565,000, which brings COVID actually to one of the most, 6 million deaths. So it brings COVID to one of the major pandemics we have seen in history. So this is the death toll. This must be about 6 million right now. These data, of course, are stable data because this refers to the history. But you see that the effect of COVID-19 is one of the most serious threats. If you compare, for example, with, of course, HIV is going on from 21, it's much worse. The Spanish flu, we didn't have those vaccinations, and also Black Death, of course, it was a total different era. We don't have the technology we have as today. So still, due to the contagiousness, you could say it go very far. If you look at the impact by WHO region, you see that in Europe we have a very serious impact, and also in the Americas, but the waves go actually quite synchronized. Also, the death tolls go quite. So, how did it happen on Curacao? The Curacao situation started with the realization that something very serious was going on. So, in January 2020, we started from the Inspector of Health and the Sector Director of Health, then that is the new acting one. We were providing information on media and also preparing the medical community. And the crisis team was activated in February 2020 as a supervising instance. The Inspector General drew back in order to supervise from distance because you have to be able to take your own measures. If the crisis team is not functioning well, then we have the authorization to take over. So we had to stand aside to let them do their work. The first restriction of inbound flights was in March 2020, from flights from Holland, because there was a high influx of cases. And but the first lockdown actually came in April 2021, and the lockdowns remain half of 2021. And also in the beginning of 2022, we had a very strict lockdown, and later on they will release piece by piece. Now here you see, actually, the first in the beginning there were cases in March, but those cases were they were not in-country transmission. These were imported cases with the secondary cases tied to them. But the real cases started actually in September 2020, where the in-country transmission in Curacao started to persist. And so there were different measures taken there. If anywhere there was a case, the school was closed. If there was a case in the workplace was shut down. So there was and the idea was that if you could have a lot of oversized measures that you could contain the situation and prevent the widespread epidemic on the island. That was the idea, that those measures, if you think later that these measures were maybe a little bit exaggerated. But besides those measures, still there was a large outbreak in December 2020. And also, this sparked different measures. We all remember that they could not all, even the churches were then shut down, and it was a very difficult year. So it continued, and in March 2021, where this is the upcoming of the here of the other variants, and you see that in March here you see a huge flare-up, and this flare-up also had a high mortality rate, where cases were all over the place, and here the problem started that you could not get all the sources. And here, a very heavy measures were implemented. Discretion, the wearing of mouth masks was admitted to be important. Before that, it was optional, and also since this was spreading all over the place, the measures were even more strict. And then with its measures, and also here, this was the first actually real total lockdown of the island. Remember, everything was shut down. There was a curfew which started from first at 10, then moved to 8 o'clock, then moved to 6 o'clock. So from 5 o'clock, nobody was to be on the streets, and already the fines for being in violation of anything were extremely high. You couldn't have any parties with also next to them. People started to have private parties in the gardens behind their houses. And there where we had the authorities with the police getting into private areas, because people thought, we've seen this before, so this too shall come to pass. So even if we would die from COVID, let's party first. So at least we didn't have some party before we died. Now, this is the kind of way of thinking that would say, yes, but what do you want? You want to die or you want to survive? People say we will die anyway. So that's a very frustrating course. And here you see also that you can take any measure from the scientific community, the behavior of civilians, they have other perspectives that might not always be the public health perspective. So based on all those measures, there was a call over there. And then again, the things went up. And then the Omicron version came up. Now, what's here, you see here that the measures taken here, actually there was a relaxation of some measures, but here the measures was a curfew, but the curfew was still permitting very early evening and early night activities to go on until 1 o'clock. And there you have the escape that still the measures were not affected anymore. And then you had the Omicron coming in. The Omicron coming in November 2021. You see also sooner or later would come in, and it did come in, and it spiked a huge wave that also spiked a lot of cases, and that would go down again, here with totally down again, and then back. Slowly admitting activities, and it would and still you have now and then, if you had any activity that would go on. You have King's Day, you have Labor Day, you didn't have Carnival, still people would have some Carnival-like activities and clandestine activities. So there it would be, and also you have the gradually releasing the influx of tourism, but not requiring a third day testing, not a first day testing. And as inspector, of course, we had a lot of trouble with that measure because we required first day testing. The crisis team allowed third day testing, so actually we had a 2 day for people who would be positive still to walk around and introduce more infections. Here you see, these are the mortality data. And you look at the mortality data, the most lethal periods were here. This is still the, here you see the first delta effects. Here you see the other delta effects. And also the outbreaks, of course, spike. Also a very high spike in mortalities. Here you can see daily number of deaths of 3 to 4 people dying daily, every day. And that was, of course, quite dramatic. The hospital was totally overwhelmed. The ICU was stretched from 16 beds to 48, and then you had an extension to 96, and the regular care had to be stopped. And then, after the dramatic measures, you see that the things go down, and also that the deaths always come after a few weeks after the incident cases. So the deaths came a little later on, and here you see in September again, and here you see where the Omicron comes in again. There is a spike also of deaths. That is not necessarily the Omicron would have been more less pathogenic, but if it is less pathogenic, but still spreads among a greater amount of people, the absolute number of deaths will still go up. So, and if you look at the last 6 months, the situation came to a little bit to a rest, and here you see gradually the situation comes down, and here you see, of course, the you see spikes of activities, King's Day, Labor Day, and then you see here again other measures, sanctions, and other activities. And here you see the Flag Day, the day of the flag in and flag of Curaçao. Here you see some activities with a lot of people. You also have international saving days where people were massively visiting those events. So you see them still in the spikes. Now, if you look at the data until these are the data until 2 days ago, and here you see the cases have gone down in very small amount of cases per day, but still here and there some spikes. What will happen here? We don't know yet because this is the BA5 threat that is now in motion, so we will see what will happen there. The number of deaths also have come to a still stand in the last months, so the situation seems to be very, very quiet. Here is a number, this should be 2 deaths. Here it shows only 1, but there's another one that should be stay there. Those deaths here, most of the time were older people, and most of the time totally unvaccinated. Also here, most of the people, totally unvaccinated people. In the beginning, we had a lot of mortality with people with underlying causes, especially obesity, cardiovascular disease, diabetes, cardiopulmonary diseases. So these were the most important, most vulnerable people to die of COVID. So this is here, this should be 2. Okay. So the last days, we have a wide situation. Now, in summary, so what has been happening in the beginning? Now, the total number of cases actually have mounted up to 44,500, which is actually 1/3, actually between about between 25 and 30% of the population got COVID actually at some point. At least these are the reported cases, because we assume, especially now with the Omicron cases, we have a large amount of asymptomatic cases are people who test positive at home with self-test but do not report their cases to the authorities. So you have considerable underreporting. Based on data in the United States, it is estimated that the underreporting with self-testing could be as high as 90%. So that should number the cases, multiply the cases by actually 10 based on those data. So based on this could be a lot higher. Now, the hospital admissions, 1,000, and the total number for that, that's 280. This is the correct number until, as far as we know, until yesterday. Now, the past 4 weeks, the total number of cases, you see, they have been considerably less than before. The number of hospital admissions were 4, and the total number of deaths were 3. Now, and you see the COVID testing that was done, and you see that the testing went up because the policy of testing also was changed. In the beginning, the testing was very restrictive by the authorities. This triggered a letter, of course. We called them here a bond letter from the inspector of health, saying that their testing was too restrictive, that they could miss cases. So they responded by picking up. And then here we see that the test went up. And here, of course, you see that the number of testing cases have been gone down, but you see that you have the test positivity rate, which is much higher than 5%. So it indicates a number of cases. So we're nearing the end, and you see the vaccinations were done, and here people get died of vaccination. As people go vaccinate, you see the high number of deaths, and then people start vaccinating. So the measures we already know, I'm running it up. So the social distancing, mouth masks, sanitizers, disinfection, no crowd activities. Most, of course, the total lockdowns, one of the most, and curfew, and also border control. These are the most impacting measures, and the gradually were measures for this 2022, and by 31st of May, all measures were lifted. So we've seen it here. We could and start live things again. Mr. Shift in healthcare? Sure, yes. And the actually, the time is telling me the time is up. I was intended to go up to the evening, but so here you see the healthcare actually was shifted. COVID got preference, okay? And mental health care, anxiety from economic crisis, increase of domestic violence, increase of suicide, increase of anxiety, and the massive job losses to the lockdowns, to crash tourism, and there was financial aid from government businesses and high cost businesses who the extra measures could not handle so many clients again. So the challenges we face, this is not over yet, okay? The 1980 pandemic did not last 1 year, it lasted 4 years. We don't know how long COVID will last actually because the mutation rate is there still, and the natural immunity is mostly maximum of 6 months. And there are economic ramifications now, they are countering strict measures, and people have become tired of freedom restricting measures. Okay, the first weeks it is great to be at home medically, but then after 4 weeks you think, hey, I've got to do my things. So the lessons, if you have unclear, incomplete disease spectrum and history, you're going to run into trouble to contain the pandemic in the early season. Especially if you have a new disease, you don't know what to look for. You've got to learn fast. Now, the early case definition is tied to Wuhan. Overlooked other cases. We've got lessons learned. First place of notifying epidemics can being, because here we have typically the iceberg phenomenon that where pneumonia deaths were noticed, the mild cases were overlooked, so you already could have a local epidemic going on. The cases were too much to Wuhan, where cases spread from to other countries, and the spread containment therefore was not effective. So that was the case which put us to where we are today. Thank you for your staying awake.
Very much, Dr. Kelly. We really appreciate everyone's attention to have a short break for coffee and we'll be back by 10:45. All right?
Thank you.
All right.
Okay, so good morning, Avalon staff, guests, and students. My name is Zalika Scott, and I will be presenting my research topic on the prevalence of multiple sexual partners and associations with early sexual initiation and contraceptive use, which is a cross-country analysis of 19 Caribbean countries. The other authors on this are David Ollie Picone, Aliza Williams, Rohiti Manas, and Dr. Jonathan Lambo. Next slide. The presentation will have the following outline. Next slide. The aims and study of this research is to identify and estimate the cross-national patterns in the prevalence of multiple sexual partners amongst adolescents in the Caribbean globally. Furthermore, given evidence that adolescent sexual initiation begins before 14 years of age in the Caribbean, we hypothesize that the cross-national patterns in multiple sexual partners would be influenced by early sexual initiation and contraceptive use. In addition, we explore whether indicators of psychosocial and well-being, mental health of having close friends, school attendance, and alcohol and drug use were associated with the prevalence of multiple sexual partners. Next slide. So adolescence is a critical point in one's life, signifying the transition from childhood to adulthood via puberty. During this time, physical, social, and personality developments are refined and discovered. In particular, adolescent sexual development is occurring alongside pressures from schools, peers, external environments. The Caribbean region comprises of the largest cohort of adolescents, representing about 26.6% of the total population since the 21st century. Sexual development and initiation are at the highest during adolescence, which brings along sexual behaviors like an early sexual debut, unprotected sex, pregnancy, and sexually transmitted infections, those of which are higher in the Caribbean than the global average. The adolescent fertility rate is 66.5 births per 1,000 girls aged 15 to 19 years. This surpasses the global average of 55.7 per 1,000 adolescent women. The fertility rates remain high, mainly affecting adolescents living in conditions of vulnerability, poverty, and instability. The effects of these behaviors results in the Caribbean having an HIV prevalence of 1.1%. This is between the ages of 15 to 49 years, and 1/3 of new HIV infections in the Caribbean in 2019 were amongst those aged 15 to 24. So in a previous study done representing 4 Caribbean countries, specifically Dominican Republic, Suriname, Jamaica, and Trinidad and Tobago, almost 1 in 3 boys at 31% and 10% of girls aged 13 to 15 had multiple sexual partners, and 38% did not use a form of contraceptive. Despite such statistics, sexual initiation during adolescence is problematic, which leads to unplanned pregnancies, poor health outcomes, and negative psychosocial consequences for those less than 16 years at sexual debut. It must also be noted that multiple factors such as the presence of violence, substance abuse, family dynamics, sexual abuse were associated with several sexual and reproductive outcomes. However, cultural and social constructs should also be taken into consideration when discussing the sexual behaviors of Caribbean adolescents. The Caribbean defines masculinity as a man who is heterosexual, virile, and even promiscuous, knowledgeable, aggressive, and in control of his environment, including the women around him, and femininity as being a woman being innocent, self-sacrificing, and placing the needs and desires of her male partner before her own. As well, cultural constructs of sexuality are believed to endorse both chastity for girls and limited sexual interactions within families, which would be the discussions. Additionally, Afro-Caribbean groups adhere to strict Christian sexual principles, and some Christian mothers have reported opposing sex conversations, especially those initiated by their children. So there are 5 types of systems that interact with adolescent development. The first being the microsystem, which is a complex relationship between the adolescents and immediate environment. 2 being the mesosystem, which is a major setting such as the school environment. 3, the exosystem, which are social structures that affect the immediate setting of the adolescent development. 4 being the macrosystem, referring to the culture or subculture. And lastly, the chronosystem, which is the change or consistency over time of the environment. So such a framework sets the foundation of this study that multiple factors work in an adolescent's life to shape their sexual behaviors. The study analyzed 19 cross-country data sets in the Caribbean, specifically Anguilla, Antigua and Barbuda, Bahamas, Barbados, Belize, British Virgin Islands, Cayman Islands, Costa Rica, Curacao, Dominica, Dominican Republic, Grenada, Guyana, Jamaica, Montserrat, St. Vincent and the Grenadines, St. Kitts and Nevis, St. Lucia, Suriname, and Trinidad and Tobago. So all of which were taken from the Global School-Based Health Survey to examine the prevalence of these multiple sexual partners associated with the early sexual initiation and contraceptive use in Caribbean adolescents aged 13 to 15. So we collected this data such as age, gender, family structure, age at sexual initiation, number of sexual partners, contraceptive use, alcohol use, perceived social support, were all associated with the increased risk of sexual behavior. Next slide. So for study rationale, a study conducted examined the association of how age of substance use and variation in use were associated with an increased number of sexual partners, showed that there was a clear pattern of an increased risk for a higher number of sexual partners associated with an increased risk of substance use. Another study examined groups who tend to have a greater or fewer partners over time, a more robust index of sex with multiple partners than has been examined in cross-national data, may particularly explain the elevated risk for STIs amongst emerging adults. The multiple partners class had the greatest odds ratio of reporting sex without protection against STIs and pregnancy, followed by the single and rare classes. Next slide. A study conducted identified trajectories of numbers of sexual partners from adolescence to emerging adulthood to examine whether individual and family factors predicted membership in these distinct pathways. As well, other studies suggest that the home environment, peers, and school experiences that adolescents have could play a role in increased promiscuity and possible unintended consequences such as STDs, altered self-esteem, and unplanned pregnancies. Next slide. A study also showed that adolescent sexual behaviors, such as patterns of first oral, vaginal, or anal sex, affected young adult health outcomes, such as STD risk and increased lifetime number of sexual partners. Lastly, a study also concluded that adolescent girls and adolescent boys, to a smaller degree, face barriers to using condoms when partners are age discordant, drinking, or met in public. Potentially reduced condom use with risky context partners is explained by adolescent girls' expectations of partners' negative perceptions of condom use. Next slide. So the methods of this study, our cross-sectional study used data from the World Health Organization sponsored global school-based student health survey. They used self-administered survey questionnaires which collected data from secondary school students age 11 to 17 or 18 with the aim to examine the impact of demographic factors, health behaviors, and protective factors on adolescent health and well-being. The samples were obtained through a two-stage cluster sampling. In stage 1, schools were selected by systematic random sampling with a probability proportion to their school enrollment size using a random start. In stage 2, all classes within each selected school were included by systematic equal probability sampling with a random start, as well all adolescents who were sampled in the selected classes were eligible for an interview. Next slide. We also assessed public available data on the WHO website and used the most recent data from the GSHS from 20 Caribbean countries between 2007 and 2018. However, we did start with 20 countries, but after we did eliminate one, which was Montserrat, due to the sparseness of data. And if a country had conducted more than one GSHS wave, we extracted data from the most recent survey. And after informed consent, interviews were conducted for all participants by survey administrators who were trained prior to the start of the survey administration, and survey procedures were designed to protect student privacy, therefore maintaining confidentiality. Next slide. So all adolescents were asked if they ever had sexual intercourse. If yes, they were also asked to report their age at first sexual intercourse and whether they had sexual intercourse for the first time before 14. And this will be shown in Table 1. Adolescents were also asked whether they had sexual intercourse with 2 or more partners and whether they used a condom during that last intercourse. As well, all analyses were performed using Stata AMP version 14. We accounted for the sampling design complexities such as stratification, weighing, and clustering using the SVY estimation command for survey data. Next slide. So this table shows the definition of variables. All variables were binary variables, which means that they were categorical variables that have 2 values, except for age at first intercourse. Our main outcome-dependent variable is multiple sexual partners with sexual intercourse before 14, and condom use, which was an independent variable. As well, all variables were coded 0 for no and 1 for yes. Next slide. As well, we provided descriptive data, means and proportions for the whole sample and by country on the prevalence of multiple sexual partners and other sexual and psychosocial factors. The analysis was then restricted to male and female adolescents to focus comparison of sexual and psychosocial factors between the 2 gender groups. We tested statistical significance between countries within gender using ANOVA test and chi-square WAL test for means and categorical variables respectively. Analysis of association of multiple sexual partners and early sexual initiation and associations between these individual psychosocial factors and multiple sexual factors, as well as the early sexual initiation, were undertaken first using cross tabulations and chi-square test, and then using multivariable logistic models. Models were also tested for cross-level interactions between early sexual initiation and individual psychosocial factors, which were stratified by countries. And stratification is one of 5 methods used for controlling a confounding variable, which was looking at the relationship between exposure and outcome at the level of age. Next slide. So our first result for prevalence of multiple sexual partners, the overall population prevalence of multiple sexual partners was 13.8% with a 95% confidence interval between 12.1 and 15.8, and all the p-values were statistically significant. It varied from the lowest to 6.6% in Costa Rica to the highest, 27.5% in Dominica, and overall by gender, 5.5%, which also had a 95% confidence interval with 4.5 to 6.8 in girls compared to 22.6% in boys, with a confidence interval between 19.5 to 25.9. Adolescents were far more likely to have had sexual intercourse with 2 or more partners if they reported to have had sexual intercourse before age 14, which was 63.1% compared with 40.5% to those who have not. Next slide. So there was no significant difference in the proportions of condom use in adolescents who reported to have had sexual intercourse with multiple partners. This was 58.1% compared to adolescents who have not at 52.8%. However, the influence of condom use is of borderline significance in boys at 66%, while it appears to have no significant influence in girls at 38%. Next slide. So this table shows the variation in prevalence of multiple sexual partners by the psychosocial factors. Here you can see the highest prevalence is yes to current drug exposure in the last 30 days with marijuana, followed by current alcohol consumption in the last 30 days. And as well, all p-values here were statistically significant. And as you can see by the chart, all the yeses, especially for did not have close friends or miss classes or schools, had the highest prevalence percentages. Next slide. Figure 1 here shows the cross-national patterns in the prevalence of multiple sexual partners by gender, and together with the total prevalence and the median of country-specific prevalences. So here the prevalences ranged from 9.3% in Costa Rica to 42.4% in Jamaica for boys, while the values for girls varied from 3.5% in Suriname to 18% in Dominica, and the median prevalences by gender was 22.4% in boys and 6.6% in girls. Next slide. Here, this table shows the sexual and psychosocial factors amongst adolescents by country. So the number of adolescents surveyed ranged from 813 in Anguilla to 2,836 in Trinidad and Tobago. The mean age of those surveyed was 11.7, ranging from 11.2 in Bahamas to 12.9 in Cayman Islands. And again, all variables here were statistically significant. And the weighted prevalence for adolescents engaging in sexual intercourse before 14 was 51.9%, ranging from 14.8% in Curacao to 83.5% in Bahamas. And adolescents from St. Vincent and Grenadines at 34.5% were most likely to engage in intercourse with multiple sexual partners, while adolescents from Costa Rica displayed the lowest likelihood of engaging in intercourse with multiple partners at 10.7%. And the country with the largest proportion of marijuana usage within the last 30 days of data collection was 25.1% in Grenada, while only 4% of adolescents in Dominica reported marijuana usage in the last 30 days of data collection, constituting the lowest prevalence. Next slide. Here, table 4, it shows the psychosocial and sexual behaviors in boys and girls. So we observed significant differences between countries across all variables. The prevalence of sexual initiation amongst boys varied from 14% in Jamaica to 88.7% in British Virgin Islands. The prevalence of sexual initiation for 14 years amongst boys varied from a low of 14.9% in Dominica to a high of 88.7% here in British Virgin Islands. And amongst girls, the lowest observed prevalence at sexual initiation before 14 was Cayman Islands at 11.7% and the highest in Bahamas at 74.1%. And as observed in general, boys reported significantly lower mean age at 11.5 than girls at 12.2 at first sexual intercourse. As well, boys reported significantly higher drug use at 8.1 than girls at only 4.8. And they were also more likely to miss class or school without permission. So for boys, this was 29.2% and girls was 24.5%. Next slide. Here we present the results from the univariate logistic regression. So there was a significant positive association between substance use, school attendance, school friends, and having 2 or more sexual partners. As well, all the p-values were statistically significant here. Next slide. So table 6 here shows the crude and adjusted results for the association between multiple sexual partners and sexual initiation before 14 years of age, which was adjusted for psychosocial factors and stratified by effect modifiers from the logistic regression analysis. So the crude analysis showed that there was a strong evidence of association between multiple sexual partners and early sexual initiation, although associations were significantly stronger in boys than in girls. The logistic regression adjusted estimates indicated weak confounding by gender, a strong confounding by current drug use, which was 51% higher, and increases strength of early sexual initiation as positive effect. And the effect modification by condom use, which was no versus yes, current alcohol consumption, no versus yes, and school attendance. As well, the association between early sexual initiation and multiple sexual partners varies by the level of gender, girls versus boys, current alcohol use, school attendance, country, which was 19, and condom use. So when an association varies by the level of a given variable, we call that association interaction, and the variable is called an effect modifier. So in this analysis, the gender turned out to be a weak confounder. Now it is generally accepted as an effect modifier. As well, the logistic regression adjusted pool odds ratio and is represented unless the stratum-specific estimates differed substantially. Next slide. Here in table 7 shows the early effects of sexual initiation on multiple sexual partners by the level of current drug use, although the strength of association varies across countries. For example, in Grenada, adolescents with a substance use had 63 times odds of having had sexual intercourse with 2 or more partners compared to Grenadian adolescents with no substance use. So there was a significant positive association here seen between early sexual initiation and multiple sexual partners across countries, although the association was not significant in St. Lucia. And there is therefore good evidence suggesting that early sexual initiation did increase the odds of having sexual intercourse with two or more partners amongst Caribbean adolescents. And data from Antigua and Barbuda all the way to St. Kitts and Nevis, there was no observations because the data was very sparse. Next slide. So a discussion of the summary that we found here. Our results show that the overall population prevalence of multiple sexual partners is 13.8%. The prevalence of multiple sexual partners varied not only by country and gender, but also by psychosocial factors and early initiation of sexual intercourse. Our data did confirm our hypothesis that early sexual initiation would substantially explain the differences in cross-national patterns of multiple sexual partners. Next slide. So the strengths of the study. It was very population-based. Prevalence estimates form complex multi-stage cross-sectional surveys which accounted for stratification, clustering, and sampling. There was also low probability of recall bias referencing the past 30 days for psychosocial factors of substance abuse. There was also a moderate sample size, and data collection was important for the confounders such as sex of adolescents and age up for sexual intercourse. Next slide. So the weaknesses of our study, the interviewer administered these questionnaires, which could cause some possible social desirability bias for some questions such as substance use and school attendance. There was also a cross-sectional survey and thus temporary order of multiple sexual partners and early sexual initiation could not be determined. Next slide. So in conclusion, the results of this study suggested that overall prevalence of multiple sexual partners and concomitant influences of early sexual initiation would reduce if the school-based health promotion policy were put in place to target adolescents at an early age and boys especially to promote healthy sexual behaviors to address the highly prevalent sexual promiscuity, and mental health wellness programs to address the problem of substance abuse, which could lead to an increased burden of distress at early age. Next slide. So this is a list of references that were used during the study. And that will be all for the presentation. If anyone has any questions, they would be greatly appreciated.
Okay, Dara, you are the next. Please turn on your camera and microphone.
Can you see me now?
Yeah, we can hear you.
All right. So, hi everyone. Hopefully everyone knows me, and for the people that don't know me, my name is Daraf Patel. I am a medical sciences 3, so third-year student here at Avalon, and I'm currently in Chicago doing my psych inpatient core rotation. And Dr. Lambo gave me the opportunity to hopefully motivate our students and give them some insight as to how to approach the Step 1 USMLE and the CBSE comp. So some of the questions that students may have are, what is really being tested on this exam? And some of the things that student really struggle to understand is what sort of student they are, where they stand as far as these examinations go, and understand what sort of knowledge gaps that they may have. And I'll share my strategy for CBSE today and the Step 1. And then I'll also talk about the most important topic to boost your scores last minute. What question banks I used and what question banks you should be using. What is the difference between USMLE Step 1 and the CBSE comp? What topics are being focused on Step 1 now, and then I'll share obviously my strategy for Step 1 as well, and how does a hypothetical Step 1 dedicated period look like. So before we get started, obviously These are my sole honest opinions on what happened to me and my perspective on how I approach these set of exams. My views are obviously based on my own personal experience, and I hope that you can take away from my experience and learn something. So, what is the CBSC? The CBSC stands for Comprehensive Basic Science Exam, and this is where the name comes from, the comp. The exam is designed to evaluate how much knowledge a student has consolidated over the first 2 years, the basic sciences. And the questions are primarily first, second order questions, and very rarely tertiary order questions. And there's a greater emphasis on the general part of the basic sciences. These are very basic questions, and they're general topics. And so, I really want the students to take their CBSC without any delay. I know that we're given a couple of attempts right after our Med 5, but I want everyone to attempt their CBSC as soon as the first week comes around after your Med 5. And let's say you take your CBSC and there's only two outcomes. You either pass or now you know where you stand if you don't pass. And hopefully this presentation can resonate with people who didn't do so well the first time around. So this is what I was talking about earlier. What type of student are you? With the new changes in the percentage from a percentage equated correct score versus the 3-digit score that we had before. So if you're either a student who previously had a 150 or below, and now if you're a student who's scoring 40% equated correct or below, I have an advice for you. And again, I have advice for people who are somewhere in that middle range of 41% to 54% equated score, and people who are above 55% equated score correct. So for the people who are below the 40, I generally advise to read chapter by chapter because review is your priority. And you can take notes as well. Questions will obviously be very minimal at this stage because there's a greater knowledge gap as far as the students in this category go, and maybe 100 questions max per chapter. And obviously you want to be doing these questions untimed tutor mode. There's no need for rushing through the questions without getting a chance to read them. So really spend some time reading the questions in tutor mode without a time constraint. And for the students who are in that kind of middle range, 41 to 54% equated correct, which was previously 151 to 180, you really want to focus on a targeted review. So you're not doing a full chapter review of every single chapter. You go to that specific chapter and pull out that first 8 page and you just read about that topic that you consistently tend to get wrong. Don't try to take a lot of notes if you're somewhere in that middle category. Most of your time, 60 to 70% of your time will be spent doing questions, which is purely application for the most part. And obviously you'd want to keep your questions either subject by subject or random, and you want to be on time blocks at this point. If you're missing questions in your question banks by having it timed, don't worry about it. Just continue under a time constraint. That way you build up that anxiety from beginning to do questions under a time constraint. And if you're a student who's above the previously old curriculum 181 system and someone who's above 55, so above 181 and above 55 equated percent correct, questions will be your only primary source of learning with very occasional topic reviews. And all your questions are going to be random time blocks. So you can kind of start to organize yourself in one of these 3 categories and really understand how you need to approach yourself even before your first CBSC or before your second CBSC. And it can really help you decipher what you really need to do from the get-go. And so my strategy for CBSC was based on something called the general topics that are supported by the Reddit medical community. So Reddit is a website where people from all over the world talk about many different topics, and they have one specific subcategory for USMLE preparation. And these are the topics that they all swear by. And so obviously we've all done these topics throughout our basic sciences, and spending some extra time during our dedicated period or Med 5 period with Kaplan on these topics would really help. So chapters 1 to 6 of Pathoma, a lot of the questions are pulled from just these 6 chapters, because again, chapters 1 to 6 are just basic concepts, just basic concepts of pathology. And a lot of the basic concepts of pathology go hand in hand with Dr. Suma's pathology lab class. So I really urge everyone to pay attention to the lab portion of pathology as well, as far as Pathoma chapters 1 and 6 also go. Obviously, first aid, full HEMOC chapter needs to be done. It's a heavy chapter, but it yields a lot of points. And pharmacology, I suggest everyone tags with a sticky tag every single chapter in first aid of the pharmacology chapter. So cardio pharm, renal pharm, general pharm, psych pharm, neuro pharm, tag every single pharm and just do all the pharmacology chapters just by themselves. Microbiology, you want to focus on, again, first aid clinically relevant sections only, plus tag along the extra sketchy micro videos and watch them with your daily morning coffee. Watch them on 1.5x, 2.5x, 2.0x, and then keep repeating them. And immunology, obviously you want to learn the entire topic, but for the CBSC, again, the main focus tends to be just a select few chapters. For example, the ones that are identified are transplant rejection, hypersensitivity, subtypes, blood transfusion reactions, and immunodeficiencies. And again, you want to know the entire chapter, but these few topics are tested time and time. And for pathology, cardio, gastro, MSK, neuropsych, and renal are one of the heavy hitting subjects on pathology. And I'll show you kind of the breakdown on the next slide, hopefully, and it'll basically prove that. And physiology, acid-base physiology, cardio, resp, and endocrine are always heavy hitters. And the reason why I highlighted endocrine is because endocrine is a chapter where physiology is basically all of endocrine. If you understand the physiology, pathology kind of just becomes a working basis of your physiology. So you really want to focus on that physiology chapter for endocrine. And a lot of students tend to lack, and I know I lacked endocrine really badly, and it really yielded me a lot of points. So the suggestion from the online website Reddit really came in clutch. So just over here, if you'd see in the breakdown of CBSC, they have some of the breakdowns, and if you notice, cardiovascular system is 7 to 8% of any person taking CBSC, and these are most recent breakdowns from a student who took their CBSC. And if you notice over here on the bottom, biostats and epidemiology and population health, basically everything that Dr. Lambo teaches us, is 6% guaranteed on your CBSC. And the best way to study for that is the first aid, 21 pages, which is really tiny, and you're guaranteed 6% on your exam of those 21 pages. So I really emphasize people to go ahead and look at the public health chapter and do the videos and go through the questions for it. But one of the things I also want to add is that a lot of the schools in the US and other Caribbean schools, I won't mention names, but they've started to implement this specific YouTube playlist, which is created by someone called Randy Neal, Biostats. And Randy Neal is a psychiatrist in Florida, and he basically teaches biostats only for step 1, 2, and 3. And he's created a free playlist, which is a couple hours, and US schools are just posting this as the module for biostats, and that's it. There's no classes on it. Just those videos, and that's it. And I also use that, and honestly, that also boosted a lot of my points. As far as memorizing the equations go, I learned how to memorize them just from those videos on YouTube. So there's a playlist out there for that if you want to search that, or I can give a link to it after my presentation. And as far as what QBank should you be using for your CBSC, anything. If you have a QBank, just use it. Any QBank is fine. I personally use RX, but I would recommend you use UWorld because I know it took me a long time to finish my UWorld the first time. And so I just hope that all of our students use UWorld from day one of med school. let alone Med 5. I mean, if you're already in Med 5, please get started with a Kaplan. That way you build up some confidence with Kaplan or RX, and then you can switch over to UWorld, but I leave that up to you. So what is the difference between CBSC and Step 1? CBSC is generally a little tougher by design. It's kind of this exam that wants to make sure that you succeed for Step 1, and that's the reason why our school has a set limit for you passing the CBSC. You really want to hit that limit and a little bit above that if even, because if you score above the school's requirement, you're guaranteed you're going to be passing Step 1. And with it now being pass or fail, I know everyone sitting here can do it. And Step 1 is a little less variety of questions. Step 1 focuses more on a select few topics, especially public health. And Step 1 emphasizes a few other topics, and I'll discuss that further on in the presentation. So I kind of put this slide over here. I personally felt CBSC was kind of like mile wide but inch deep, and it was testing kind of the breadth of the knowledge and not really in depth of everything. Whereas Step 1 was kind of testing specific select few topics, and it was trying to test every single thing you know about that topic. Now, I'll discuss what are those topics a little further onto the slide, but I just threw this in to kind of alleviate some anxiety that students may have. So what topics are being focused on Step 1? Topics tested on Step 1 are emphasized by the forms that are posted by the MBME. The examiners themselves are basically hinting you that, hey, these are the example questions we want you to take before you come and sit our exam. And it was true for me. I took every single NBME online. You can do them offline if you can find them, but genuinely do them, and then whatever you get wrong, memorize them, because the emphasis on your exam will be those topics. Not the same questions though, but they'll be the same topics. And the most emphasized topics are in these MBMEs, and it's right there for you. So I took them, and I found that 28 was very tough, and number 30, MBME 30, was the most fair, and MBME 25, 26, 27, and 29 are marginally a little bit easier than the real exam. And the Reddit community, again, that same website, they have done a slope y-intercept, and they found that the slope was more steeper for MBME 28, and it was a little bit more flatter for MBME 25. Again, just going to show that MBME 25 was a little bit easier, and 28 was harder than the exam itself. So now for my strategy for Step 1, UWorld, that's it. By this point, you would have completed UWorld 1 round during your CBSC. And if you were using another QBank before this, I suggest you start UWorld at this point. If you're using UWorld from the get-go, obviously it would work in your favor. The idea with UWorld is, you want to build up stamina. You want to start by doing all random time blocks. This is post CBSC now. You've already passed the CBSC, and now you're already registered to take Step 1. So you want to simulate the exam from the beginning of your dedicated period. Initially, start by doing just 1 block a day, and then review them fast, and then aim to do 2 blocks, and then review them fast, and then ideally go up to 4 blocks a day. And I'll show you again in the next slide how to review blocks fast, because I don't think everyone knows about this yet. And I throw in this little slide at the bottom, the meme. It's basically, at some time you'll basically start to feel a relationship with your UWorld, and it's a healthy relationship. Perfect practice makes perfect. Do all your blocks under an exam situation. Noise isolated room, put on your earplugs, no distraction should be there while you're doing a test, no friends, no family, no phones, no music, no coffee, no water, no laying down. Be at your desk in a quiet place, because that's how you're going to write your CBSC, and that's how you should be writing your Step 1 also. So don't deviate anything away from what the real exam is supposed to be. And start wearing a mask. while you simulate these exams. Even the UWorld exams, when you're doing a block of questions, wear a mask, because on your exam, you will be required to wear a mask. And I kind of missed a little bit on this one, because I didn't know that my exam would require me to wear a mask, and I was not fully trained over time by myself. I didn't sensitize myself to the mask, and I kind of had a bad reaction on my skin during the exam. But I want everyone to experience that beforehand, before going into the test center, and so you can get used to it. And one of the other things that student might not be aware of is that you'll be given a laminate sheet while you're in your exam and a black marker. So learn to take your UWorld test with a laminate sheet and a black marker. That way you have that same sense of, oh, I want to write something down, or I want to calculate a specific formula quickly. You can do that while you're doing your block. And again, you have to remember that step one is hard and step one is important. Not everyone's going to know the importance of it. So you kind of have to take a step back and remove yourself from certain social situations that may be presented to you. Now, let's say your UWorld scores are stuck. Let's say you're plateaued 30%, 40% on every single block, you're 50%, 60, or whatever it is. How do you break this plateau? And this strategy applies even before your step one. How do you break a plateau while you're trying to study for your CBSE exam and you keep getting the same score and you're reviewing chapter by chapter? There's something called triaged review. Back in the day when UWorld started off, they used to have a instruction manual with it. They no longer have it now, but it was called the triage review. So triage review is a method of reviewing blocks, and you triage your review. So it basically identifies what is the most important thing to review on a UWorld block. The questions that are very easy, and you miss those questions, that's what's more important. Because if a question is hard and you missed it, you're kind of part of the mass. You don't want to be that one person who gets an easy question incorrect. So how do you determine the percent ease of a question? I'm sure everyone knows already that UWorld questions come with that little bracket, percent others got correct. And that's how we determine if a question is supposed to be reviewed. And so if you go into a UWorld block and you pull out any random block that you did, and you go to a previous exams or previous test, then you go into that block that you've just recently finished, you would go down over here where it says, I think it was results, and then it would open up the test results over here, and you would organize it by percent others correct right over here. And then it would go down into a descending order from 91% to not 91%, 87%. So it goes from 100, the easiest questions, all the way down. And then you would just click this button right over here once you've organized them. And if you notice, they're going to start by a random order, but the order is percent others correct. That way now you know if you got a question correct that 91% of the people got correct, that's not something you need to read over. But if 84% of the people taking this test or taking this question get it correct and you got it wrong, that's a deficiency you've identified. And that's something to focus on for that block. And so once you start that block by clicking this button over here, after you've organized it in a descending order, the questions will populate from easiest to the hardest. So if you notice, the first question is the easiest, 91% correct. But if you go to the last few questions, 34% of the people answered it correctly, and I answered it incorrectly. This is not something I would focus on initially. I would get to it eventually, but if I'm lacking at a question that was 84% correct and I got it wrong, I would focus on that first before I even make it to this question. So now, what does a dedicated period for step one look like? You know, for me, the first week I started off doing one block a day for 5 days a week. And then on the weekends, I would review it basically with this triage method that I just identified. And then during my week 2, I opted to do 2 blocks a day, 5 days a week. And then my week 3, 3 blocks a day, 5 days a week. And I had about 1,200 questions done in 3 weeks. You can, for example, let's say hypothetically, you get 30% correct. out of those 1,200 questions and you got 70% incorrect, you don't necessarily have to review all of the 70% incorrect questions, because of the 70% incorrect questions that you got, maybe half of them will be the ones that you need to review. Like 80% people got it correct and you got it wrong, 90% got it correct, you got it wrong. So half of those would be something you need to review on. And let's say you review the half of the incorrects, that's 420 questions to actually review. And you can go ahead and triage that review while you're doing your blocks in week 1, 2, and 3. And if you need additional time, which I did, on my 4th week, I spent 1 week to go over incorrects with highlight, and I just kept reading them that week. And moving on to week 5, again, I continued with that same flow of 2 blocks a day, 6 days a week. Highlighted the most easiest questions that I got incorrect, and I completely ignored the ones that were considered difficult based on percent of the people correct, and I completely ignored them for that time being. And then I continued on to week 6, 3 blocks a day, 5 days a week, and I had 10,080 questions done in 2 more weeks, and that's almost done the U World, 2,280 questions. Now, at this point, you want to evaluate your performance. So at week 6 end, you want to kind of take a step back and say, how are your scores? Are you trending up or down? From the beginning of your 1st week till now, at the end of the 6th week, do you see a trend? In UWorld, it shows you a trend of performance. Do you see trending up? Even if it's a little bit, did you notice a high score? Did you notice a new high score? Or did you hit a new all-time low? How much are you sleeping? Do you need more breaks? Are you taking too many breaks? Do you need more specific review for selected topics? Are you getting the same questions wrong? These are the questions you need to ask yourself. And one of the things you also need to ask yourself is, are you diligently doing something to improve your scores from 2-3 weeks from now? People ask me all the time, how many more questions? Just keep doing questions. There's more questions to always do. Just keep doing questions. And once we're done week 6, we're going to do more questions. Week 7, I started off by doing a rapid review of the topics that I had been getting incorrect again and again. And during week 7, I fixed and sort of patched up a few of the loose ends there. And week 8, again, go over all the triage incorrect questions again, the same questions that I had been doing before. And then I kept doing new questions. So 3 blocks a day for 5 weeks. That's 600 more questions. And on the 7th day of that week, I decided to take an MBME. And that kind of tells me where I'm at. So this is one I decided to take. I think it was 25. I took them all in order. So I took MBME 25 at the end of the 8th week. And then it sort of tells you where you stand as far as MBME goes and your UWorld. And then week 9, again, carried that same energy through. 3 blocks a day, 5 days a week, 600 questions. Review the most important triage review questions. And then take 2 days to review another MBME that you do on that 7th day of week 9. And then once you're done that, you sort of approach this week leading into step 1. You should be done UWorld by now, and you would have done at least 2 MBMEs. This leaves you with 2 UWorld self-assessments and 4 MBMEs currently. MBME posts new MBME forums, so hopefully 31 to 36 will come out soon. But until the time that they don't, they will keep the focus on 25 to 30. So you'll have 2 UWorld assessments, 4 MBMEs left. And if you're satisfied with your performance so far, I suggest you do the remaining MBMEs within 2 weeks and review them. Start reading them again and again and take your step 1. And if you are not satisfied with your performance, take an additional 4 weeks. You're allowed to push your step 1 within that window by paying, I think, $100. And it's totally worth it if you don't feel satisfied with your performance. But don't delay your exam too much. 2 weeks to go over weaker concepts and MBMEs, and 2 weeks to complete the remaining MBMEs. And the last week of your dedicated, read the 6 MBMEs inside out. They provide the answers online now, and if you go look up on other forums or friends, they can also provide you with the MBMEs with picture illustrated answers. So you really just want to read these MBMEs the week before your week before your exam, because that's where the focus will be. And some of the other tips, obviously this exam is specifically designed to test the student's knowledge, but it also tests your psychometrics of being a test taker under a time constraint. The exam itself accounts for the time crunch it's placing you under. Everything in your exam is purposeful and deliberate. There's no such thing as a spelling mistake on the exam. There's no such thing as a missed comma or a missed period on the exam. Everything is deliberate. If you see something that does not seem right, chances are it's there to confuse you. And I hope everyone knows the exam is 280 questions. However, 80 of the 280 questions are not real. They are only there as an experimental purposes for next batch of students who take the exam. And those 80 questions will never be used for a single point on your exam. But the sad part is you won't know what 80 questions are experimental out of the 280. They spread them out all over. And let's say if you are stuck on a question and you feel like this question is impossible, you have no idea what's going on, chances are it's probably an experimental question. There's 80 of them in the exam. So pick something that's very common or your first gut feeling and move on. Don't waste any more time on it. And just ending off, my advice for Kaplan, attend every single session. I personally did the whole Kaplan session diligently. Dr. Barone even added me on Facebook, and he loves to have a chat with you if you message him. Stay in touch with the faculty at Kaplan, because this is probably the last time you'll ever get to answer questions. I want everyone to do it once, and I know everyone can do it right and get through this, because after you're done your boards, it's off to the wards, and in real life, there's no second chances. So, really spend that time asking questions and learning. And just ending off, I left another meme in because I like memes. So you'll find UWorld questions as obscure as, UWorld asking you 22-year-old female with chest pain who is 12 weeks pregnant, and your gut feeling says it's a PE, pulmonary embolism. But then UWorld will hit you a curveball with history of scoliosis and being short, and the answer is aortic dissection from Turner syndrome. And then you're going to rage, why would you make a fictional Turner syndrome patient pregnant? And then UWorld will tell you, although rare, spontaneous pregnancies can occur in up to 5% of the patients. So you are going to rage at some of these questions, but understand that they're designed to kind of mess with your mind and kind of mess with what you already know. So be confident with what you learn and go with your gut feeling always. And yeah, that is all. If anyone has any questions, I'd love to answer them.
I focus on the hyperphosphorylation and phosphorylation state of the NS5A as a target for our target of therapeutic approaches. The reason is that this NS5A hyperphosphorylation, specifically its site, is conserved throughout whole genotype, not whole genotype and not cellular. And it's very critical for the virus life cycle and for the protein itself. So we wanted to understand how it works, if we can use it, because if we can develop something on it and we understand the pathogenesis, the mechanism of action, then we could develop or we could help in the development of the drug that could be used for all the genotypes and even for the mutants. So the methods that I used was molecular genetics. So first thing, because we have worked with the actual virus, especially when we are trying to study translation, so there's another problem with the SCD using the real virus is that it's not compatible. You can rarely work with actual live virus in the lab. So that's why we first generated SCD RNA translation reporting. So we say reporting because it reports us how much translation is going on. So this reporter is the RNA. It's positive sense, it's like an mRNA, it will translate automatically in the cell. But what we did is that we added the reporter called luciferase gene. Actually, this gene encodes for a protein called luciferase. So we put this protein, so this reporter protein luciferase
if you add chemicals and you can detect how much it is, because it gives you color, and you can use a machine illuminator and then you can read how much protein you have. So that's why it's a report, and this will report us how much translate, like how much RNA has translated. So another thing we also did is that because we are studying translation, we don't want our study to be affected by the replication, so we made sure that these are replications effective. So based on literature, we did mutations like GDP deletion and NS5B. So NS5B is the RNA-dependent RNA polymerase. So this is the protein that is responsible for the replication of the virus RNA. So we knock out that protein. So that means like we just make sure that that protein doesn't work. So it will not replicate the RNA. So we have a study or we have a report giving us only the translation values. So this is how the structure of the RNA was supposed to look like. So after the RNA, because we are looking for the effect of the protein on the translation of the RNA, so this is, we also make the mutation for the protein itself. So for the protein, what we did is that we made a plasmid rDNA that encodes for the protein itself, and we made mutants. So the mutants were like this. So firstly, because we are looking for hyperphosphorylation, right? So as I said earlier, this is the site responsible for the hyperphosphorylation. So these are like almost 6 of the serine residues. So first thing we did is like, we either mutated them to the aspartic acid. So aspartic acid is a negatively charged. So we know phosphate is also negatively charged. So we are mimicking the negative charge. So this is like hyperphosphorylated mimicking protein. And here we have the Avalon mutation, which is like serine alanine. So alanine is a neutral amino acid. So this one will never get phosphorylated. So this will be always hypophosphorylated protein. So after that, what we did is like we used the Hugh-7 cell lines. So cell lines, because like these Hugh-7 cell lines are the permanent linear cell lines that we use commonly for the study of hepatitis B viruses. So what we did is like we had the reporter RNA that has the luciferin gene in it, and we had plasmids that encode the NS5A, either in one side or in a mutant. And we put them together, we used like transfection reagents, and then we use that reagents to insert those RNA and DNA in the cells. So once the DNA and RNA were in the cells, then we left them for 24 hours so that those proteins will get expressed, the RNA will get translated, and everything will work. So after that, we did the harvest. So we took out the cell, we lysed it, we took the extract, and then we did the luciferase assay. So luciferase assay will be looking for the luciferase protein value, and it will give us the level of translation going on. And then we also did some Western blot, because like once you do something like this, you always need to back it up with a Western blot, because Western blot will show you the level of your protein that is being expressed. So suppose you say, oh yeah, I have a luciferase expression of like 100, and then you want to show that it's the protein that is helping it. So you have to back it up the Western blot. Because Western blot will show you how much protein you have. So this is the first result I got. So what we did is at first we used the we use the 6A and 16 mutation. So this one has all the 6 mutated alanine. It has all the 6 of the serine were mutated to aspartic acid. This was mimicking the hyperphosphorylated. This was mimicking the hypophosphorylated. And here these are our control. So this one is just the normal RNA translation with no intervention. So there is no extra viral protein acting on it. So this is your standard. And this is the wild type. That's the normal protein with no mutation in it. So this one downregulates the translation, and we already knew that it downregulates the translation. So now these are our subject of interest. So here the 6A, we found once you mutate to alanine, so you basically making just all of them hypophosphorylated, the protein is lost of function to downregulate the translation. But now you have all the serine into aspartic acid. So that means all of them are hyperphosphorylated. So they are still able to downregulate the translation. So now, so to back this up, I have a Western blot. So here in the Western blot, this is the blood type, so this is the normal protein, and that's fine, right? So as I said before, they are always in two states, hypo and hyperphosphorylated. So you can see here two bands, hyperphosphorylated, hypophosphorylated. We need a mutation S6A, so that means all of them are hypophosphorylated. So it's the same label, we don't see any band here, so we suppose that all of them are hypophosphorylated. And similarly here in the 6SE, we have only one band, and it's at the top, so which resembles or which is equivalent to the hyperphosphorylated. And we don't see another band here, so which means everything is hyperphosphorylated. So that's also like help us to know that this all effect is hyperphosphorylated. So which says that all the hyper or the negatively more charged NS5A is involved in downregulating the translation. So once we knew like, okay, all the 6 of the serine were like hyperphosphorylated and it affected the translation, now we wanted to know like if all the 6 of them is important, or is just 1 or 2 of them. Because the more specific you are, the more better you are. So what we did, so it's the same approach, like we did the mutation, right? But this time we mutated 1 at a time. So we have 6 mutants, like 1, 2, 3, 4, 5, 6. And then, so we did the same alanine mutation and aspartic acid mutation. So one is less sharp, one is more sharp. And then we put it side by side, and then we compare how they work. So here, I circled them out. So these 2 mutants are the ones that actually stand out to us. So here, alanine. Once we did the alanine mutation in S22, it lost the function. The protein wasn't able to go down because it wasn't downregulating the translation. And similarly for S238A, where it failed to downregulate the translation again. But at the same time, this site was mutated to aspartic acid. It mutated, like, it downregulated the translation, and same with this one. So this says is that among all those 6 serine residues, although hyperphosphorylated form of NS5A is important to downregulate the translation, it's just these 2 residues in those all of 6 was like the dominant one. So they were the one actually controlling the regulation of translation by NS5A. So I also said that NS5A has a unique property of being dimer all the time. And you have to be, like, NS5A has to be dimer to perform its function. So because like we found that these two serine residues are important in regulating the translation, we wanted to know like how does it do, because like we need to know how it works. So what we did is like we hypothesized that maybe this serine residue phosphorylation is important for the dimerization of the protein. So we did an approach called speed cruciferous complementation assay. This is a little different from the before. So what we did is like we made the plasmids. So each plasmid inputs either the bait or the prey. So both of them are the NS5A mutants, and the bait will have half of the cruciferous protein, and then the prey will have the other half. And if they actually dimerize or come in contact with each other, they are in close contact, then this one and this one, these fragments come together and they give you the complete protein. And this is the only one that will give you the reading. So that means if you have less reading, then that means these proteins are not interacting. If you have high reading, then that means these proteins are actually interacting. So the same thing, we have the mutants, those 2 mutants, and then we put them side by side. So this is the alanine mutation, and this is the specific mutation site. So you have a blood type, right? So blood type, we know that they actually do interact with each other. So this is their reading, and this is your negative control. So these are the mutants of the NS5A, which actually doesn't interact with each other. So this shows that you have very low reading. So this is actually value of this assay. So now we look at the S29A here. We have alanine mutation, so that is the less negative charge. So here we don't see any change. For S238, we see no change in the activity. But now once we look at the aspartic acid over here and here, in both of the cases, the the level of the reading will decrease significantly. So which says that if you have a negative charge on these two sides, so that means that you will push the protein to interact with each other more. So that means if the protein interacts with each other more and becomes a dimer form, then they will and bind to RNA more, and then will downregulate the translation. So now I compiled all the story, all the results, and okay, so the story that we know was that the NS5 is hyper, they dimerize, they could be either heterotrophic, monotrophic, they will come and bind to the RNA in the strip line, and then downregulate the translation. Now we put our results in. So our results is that hyperphosphorylated is more involved in downregulation of the translation, and according to the hyperphosphorylation, it's the S, which one is it? Is the S229 and S238 that's actually playing a very big role in modulating the hyperphosphorylation, and it modulates by making or pushing the NS5 with the dimers more, and then bind to the RNA, and then downregulate the translation. Okay, so this is the same conclusions. Hyperphosphorylation of NS5 downregulates the SCB1B translation, similar to the wild type NS5. Phosphorylation of the serum residues S29 and S238 enhance the SCB1B NS5 dimerization, and then thus downregulates the translation. So I would like to acknowledge my supervisor from my previous school from the University of Saskatchewan. He works in the video interact, and his name is Dr. Changu. And these were my community members, these were my lab members, and this is my funding agency. Thank you.
There are any questions, sir?
So you have the exercise in the lab, right? If you have the in vitro and the in vivo cells, how do you make sure that these cells have the same environment as the human body? I'm really interested to know. How do you make sure in your lab that the in vitro and in vivo, the drug is working the same?
So we have a standard when it comes to the in vitro. So we have a standard way of doing, especially in vitro labs, right? So we use something called incubator, and it sets the time, it's sterile, so we don't have any infection. It's always set up at 37 degrees Celsius, so we are mimicking the temperature of the body and everything. So that's how we do it.
There are no limitations. There's no difference between how the incubator works and the human body works?
It could be, because
what are they? That's what I want to know. What are the limitations of this in vitro?
Oh, in vitro has a lot of limitations, right? Because it's not mimicking the whole human body. In human body, we have a lot of immune response and everything. But like right now, the main focus, this is the thing. When we are in molecular biology, we try to stay simple. We're just trying to look at this. Okay, what is this doing and what is this? We don't implement this result directly in the human. That's why we go phase by phase. Because if this one gets approved and if you find it very significant, then we move to animals. So that's where we are like mimicking the whole human system. And then only we move to the humans. So that's
really done.
Yeah. Yeah, that's the thing. I think the thing is like when the drugs come on the market, it's not like directly you test on the human. You start with the cell line, you find a control mechanism, or if you think, okay, like yeah, I can do this is how that mechanism, or this is the immune response and whatever. Then we move to animals, and animals are also not whatever. Like animals, like we pick up animals that is suitable for a system. So I think like we have mutated like mouse. So they are genetically modified in such a way that like some of its organ is like similar to the human. So that's how like, we pick, or some of it rodents and stuff like that. So that's how we go.
Thank you.
Thank you, ma'am. It's great. You know, the new COVID treatments called, it's introduces ritonavir, you know, it's a protease used in HIV. That's the way they use
to try to keep the viral protein from being split apart. So if you inhibit the protease, you inhibit the protein. So that's that Paxlovid, that's the new drug for COVID. I'm sure that Dr. saying that might be less, cause less hypersensitivity. You follow what I'm saying. In other words, when you're introducing spotty residues into a protein, you might change the immunological profile of it. I don't know. I don't know anything about virology, but I just wondered if was there a reason to use aspartame, I know pluses and minuses combined together. Is it more or less more or less allergenicity? You have, I don't know, it's a complicated question. It's like a whole PhD, but you see what I'm trying to say? I know the process is to make it bind into diet. But I don't know, I just wonder if it's, did you do this for other viruses that make drugs that, this is really total, it's not a great concept. Thank you. Big question, sorry.
So I will repeat it again. So you said that we did the mutation in such that we push the protein to come and interact with each other. And what's the immunology, changing the immunology response, right? So firstly, maybe there could be a change. I don't know. Because the thing is, I didn't do immunology. It's not immunology, right? We don't do any immunology here. The other thing is that it's not like we were pushing it to bind. Actually, this protein in its native form, in a normal form, it will come and bind to each other. So we were just checking. It's in a normal way, when it's binding to each other, what is pushing it to bind? So that's why we did the mutation. And those mutations show that if you mutate those two specific sites, they get copy. So for example, in a normal situation when you are not you are not in any interaction, so we think that if there is a postulation on those two specific sites, then the protein is pushing to go and bind to each other more. So that's what we are trying to do. We are just we are not trying to invent something. We're just trying to find what is going on. So that's what we did. So we found, we think we found that those two sites are actually the one that's pushing. So that's what it is.
All right, good afternoon, everyone. I hope everyone had a great lunch. My name is Disha Shah. This is my colleague, Diana Crosby. And unfortunately, our other colleague, Reg Bella, could not make it today, but our research is on physical exercise and its relation to bone mineral density in children in North America. Our outline for today is we're going to be talking about our objectives, stating the problem, study rationale, methods, results, and finally our conclusion. So the purpose and objective of this study is to summarize the existing evidence of the effectiveness of physical exercise versus no exercise in pediatric age groups 0 to 18 in North America when modifying the overall bone mineral density in patients over time. So I'm stating the problem. The economic cost of osteoporotic fractures is constantly rising. Fractures in the U.S. are expected to cost about $25 billion per year by 2025. And that research was done by Burge and Johnson. Pediatric bone fractures account for a huge amount of pediatric emergency department visits. The incidence of fractures is highest amongst those aged 10 and 14, I'm sorry. The annual occurrence rate for the entire pediatric population from ages 0 to 19 is 9.47 per 1,000 children. That study was done by Naranji and Mizrahi. According to Ortiz, overall upper extremity fractures account for about 70% of cases. Within the largest bone increase in this demographic, there is a growing knowledge of the importance of regular physical exercise and diet and being able to control bone mineral density. The pediatric age range of 0 to 18 years has been subjected to an increasingly sedentary lifestyle. This is because of the unfortunate COVID-19 pandemic, and it's most likely a result of the quarantine and the online school. And physical exercise should be highly encouraged within children and adolescents, not only for bone mineral optimization, but also for their maintenance. Our study rationale 1. So according to Al-Shamari and Al-Lab, physical activity, especially weight-bearing exercise, has long been known to benefit our bone health. Early childhood weight-bearing physical activity appears to have a very positive and likely long-term influence on bone strength parameters. Prior research has focused on the factors that influence bone mineral density throughout our childhood. According to Goldman and Abrams, they did not focus solely on exercise itself, but they also looked at factors such as calcium levels, vitamin D, and dietary changes. Adolescents remodel 25% of their skeleton during the adolescence of growth. And so by the time they reach the age of 20, they've already developed 95% of their peak bone mass. So the question here is, if we build bone mass throughout adolescence, is it going to help us avoid fractures and osteoporosis later in life? And the simple answer to that is yes. According to Tibet, the research done by Tibet, they had compared retired soccer players with age-matched controls who were technically not really very active throughout their adolescence, but it did suggest that those with a soccer background not only had considerably stronger bones, but they had suffered far fewer fractures later on in life. So our research questions is, in children in the pediatric age group of 0 to 18 years, is adding a daily physical exercise more effective than not? And that is when we're measuring the overall bone mineral density of children over time. Our study design was a systematic review of pre- and post-design. Outcomes were measured in groups of participants before introducing the intervention and thereafter. The PubMed database was searched exclusively for randomized controlled trials and observational studies through the years of 1995 and 2020. We had then excluded observational studies, and shortly after that, we realized that our randomized controlled trials were actually clustered randomized controlled trials, and this just means that they were groups of subjects that were randomized as opposed to individuals. And then studies included had to assess the relationship between exercise versus no exercise when measuring bone mineral density in pediatric children aged 0 to 18. Our search strategy that we used in PubMed went a little bit like this. We typed in children or adolescents or youth or pediatrics and exercise or sports or training or walking or games and bone density or bone mineral density. Filters were then added to the study design, which were randomized controlled trials and observational studies to be able to create the systematic review of randomized controlled trials. Citations were then retrieved and exported into an Excel spreadsheet and screened by title and abstract. Consensus was used to settle any disagreements. So our study procedure included our inclusion and exclusion criteria. According to our PICO model, our inclusion went a little bit like this. Number one, our patients had to be within a certain age range, and that age range was 0 to 18. Number two, exercise versus no exercise had to have been mentioned. Number three, bone mineral density was measured via dual energy X-ray absorptiometry, otherwise known as DEXA scan. And fourth, the studies had to be within a randomized controlled trial design. Our articles were then excluded if one, the population was not limited to pediatrics or humans. Two, there were interventions other than exercise. Three, there were comparisons other than exercise. Four, they had excluded DEXA scan. And five, there were any other studies besides randomized controlled trials. Our diagnostic criteria was based on 3 different things. The first being Z-score. That was measured in grams over centimeters squared of the femoral neck bone. Number 2, the use of hologic QBR densimeter, which is a full body bone densimeter. And this has showed previous long follow-up studies, previous long follow-up studies have shown that this has a lot of efficacy using this specific criteria. And third was Tanner criteria. This was used to assess maturity development and was also adjusted for any confounding factors. Each study was assessed as such, the first being randomization, which was stratified and clustered. The cluster was then subdivided into control and intervention due to that specific study setting. Number 2, randomization was deemed either stratified or not, and we based that off of our Tanner criteria. Number 3 was blinding, and that was deemed adequate, inadequate, or unclear. Number 4 was our inclusion of randomized patients, and this was also deemed adequate, but if more than 90%, inadequate if less than 90%, or unclear if the number of children randomized or analyzed was not described. Stratified sampling was observed throughout our assessment of articles. This involved dividing the population into subgroups called strata, and this was based on relevant characteristics such as ethnicity, gender, or even age. And this type of sampling helped us draw a more precise conclusion by ensuring that every subgroup is accurately represented in our sample. Here's our data extraction sheet. So as part of the data extraction process, an outline of the extraction was made and modified based on our results. The following information was included on the form to extract information. So we'll start off by going over this left side right here. So we included things such as ethical approval, and we had gained consent. Consent was obtained by all participants in the study. Original data had to have been included. Randomization, blinding of the participant or the provider, inclusion of all randomized patients in analysis, exercise intervention, and DEXA scan. And then over here on the right side, we included study type, study quality, study setting, study country, and then also induction agents as interventions such as type and category of exercise, Z-score, and standard staging. Our baseline demographic, which is right here, which is number 20. Our baseline demographic included things such as sample size, mean, age, gender, ethnicity, and even medical history. We also included intervention and control, bone location, and lastly, control over pre and post bone mineral density, pre and post intervention bone mineral density, and change in bone mineral density. Our outcomes and exposures and covariates. So the primary outcome measure used to report our findings within the study was changes in our femoral neck bone mineral density after exercise. So this is achieved by conducting the analysis of the mean with standard deviation using pre-intervention, which was the exercise, and post-intervention. Changes in femoral neck bone mineral density was chosen as it can be easily replicated to be determined if there are any changes in quantity, which is the density of the bone over time. And because the femoral neck bone has a large quantity of trabecular bone, which is the spongy lattice-like part of the bone, it tends to lose density as we get older. Our data was extracted from citations and included in multiple forms of exercise such as jumping, athletic sports, games that had included physical activity and uniquely vibration maps. The use of gold standard radiological measurement for bone mineral density, sample size, age, and Tanner criteria reduce any confounding factor.
So we performed an analysis according to the values reported by the original author. The mean differences used the baseline from continuous data and the standard deviation of the bone mineral density.
To analyze the data, we use STATA MP14 and as our statistical tool. We performed an analysis with the values that were given by the original authors. For those studies that only reported the pre and the post-interventional values, we used the STATA MP14 to calculate the t-test mean difference between the control and the interventional group, as well as the p-value, which you'll see that the majority of the studies were statistically significant. So here's our figure 1. So with our figure 1, we had 10 final resulted citations that fit our criteria. When we first started, we had 261 PubMed citations that were originally identified through our literature search. After that, we had abstracted or excluded 52 of them due to after our full article review for our first set of exclusion criteria and inclusion criteria. 28 of the articles were excluded just based on the differences of origin. And then after using that long data abstract sheet that we had, we ended up excluding another 17, ultimately ending up with our final 10. So with our variables, our covariables that we looked at, there were, and this was after like consensus between the three authors, that we decided on just using North America. So we ended up with 6 that was from the US, or United States of America, and 4 that was from Canada. We also had our study design that was pre and post, and that was for actually 8 of them. And then we found out down at the bottom, and I know you can't see it, but this part was from Bordeaux, that it turns out that it was a before and after. So what basically happened was it was the same set of children that first had the intervention, and then, but they were all randomized. But they first had the intervention, and then afterwards they watched them to see like what would happen. So it was a pre and post study. The other part that was also unique about our study was that like 8 out of 10 of them were in a school setting. There was 1 that was from a childcare setting, and 1 was based in a hospital. And we'll find out later on why 1 of them was in a hospital. The sample size of children that we used was pretty good because it was like 715. The other thing that we also pointed out was that the health status of the children. So the majority of the children were healthy children. One of the 2 articles used cerebral palsy children, and one of them was strictly for obesity children, but then later on we found out that they also looked at like the BMI of the children to see whether or not they actually was above 25. So there was that in there, even though you don't see that here, but they didn't, it was under close review that we realized that that was what was going on. The age group, even though we were looking between 0 to 18 when we first started, it turns out that infants, they don't usually do like the DEXA scan. What they do is an ultrasound. And so in order for us to narrow down on the criteria, we just excluded all the infants. So our children really starts from 3 to 18. Our 18-year-olds was only because of the longitudinal study that was done, and you'll see that that was by them. And that longitudinal study basically looked at the exercise period, but it was only a short time, and then they followed them for another 8. Like Disha said from before, we did make sure that all of the studies used the DEXA scan, the holistic dual energy X-ray observatory. We made sure that they all had that. And then we also looked to see whether or not they had the TANA criteria for maturity. Now, if they did not have the TANA criteria for maturity, we made sure that they had some kind of stratification for that set in that article, those children. The other thing that we looked at was to see whether or not there was any loss of follow-up. And in each of these 10 articles, they all talked about whether or not the child left or parents pulled them out, or if they just didn't want to do the exercise, whatever. So in those, as far as the articles are concerned, the validity of that was really clear. The types of exercise was also really clear because mostly all of the articles said specifically what they did in order to implement their intervention. So there was 6 out of the 10 here that used actual jumping exercises. There was 2 that used like games and running, dodgeball, tag, and basketball. And then there was 1, actually it's 2, that used the vibration mat, and we'll talk about that more, and a vibration mobile ability, and they used that for the ones that had several months. All right. So for our randomization, for our quality of our study, basically there was all 9, except for that pre and post one, all 9 used randomization. At least they said that they randomly selected their control and their intervention. 3 of the studies they used the clustered, and that was the clustered in terms of what Nisha had said from before, which was instead of randomizing individuals, they randomized like a whole group of children. The other one was that all 9 schools did stratify for age, gender, and maturity in their sample size, and then there was 3 studies that was actually blinded, like for real. And they did that by completely removing the intervention group from the control group. And the way how they did that was that the school itself had an exercise, like the entire school, and then another entire school wouldn't have any exercise, and they would compare it that way. Because the thing about it with the exercise group was that it was implemented within these school systems, and so even though we only have our 715 students, in some of these studies, they said that it was actually the entire school that participated in it, but only those that they got the informed consent sheets from and the parents consented to, blah, 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 that was in the actual study. So here comes the big part now. All right. So here is the data that we collected from our systematic review. And it was quite extensive. I'm going to tell you that myself. But what we basically did was we looked at all the office measurements for what they had used for their bone density on the femoral neck. And we chose the femoral neck solely because in the majority of the studies I'm going to prove to you, it did show that there was an increase in their bone mineral density over time. The authors also used numerical numbers for all of their bone mineral density, so therefore that's the reason why we can use it in terms of grams per centimeter squared. The duration of the studies, all of them was between actual intervention time now, not collecting the information, was between 6 to 10 months, and they were all statistically significant. So for the bone growth. Now the hypothesis, according to Johansson, here, Johansson thought that there would be a difference between those who were pre-pubertal versus those that were post-pubertal or peripubertal, and they thought that that would be because during the puberty time is when they have the most amount of growth. And so therefore, they didn't think that the pre-pubertal children would actually have any growth. But what turned out was that there was, the bone growth did show that the interventional group did have an increase, and that they, from baseline to 12 weeks, that they were significantly higher in the jumping group compared to the non-jumpers in the pre-pubertal, which kind of like he didn't expect that, so that was an unexpected result for his hypothesis. The Canadian study from McKenzie, this person here, they did a lot of study there in Canada regarding bone mineral density and exercises in school. They saw that there was, and for their study, the interventional group at the baseline showed that there was 0.68, and after the intervention group of exercise for 7 months, of 121 males, they had an increase in their change of their bone mineral density from 0.015 with an interval of 0.10 to 0.21, and that was versus the control group, and which was a little bit lower, which was 0.014 with an interval group of 0.09 to 0.19 at the 95% confidence interval, and there was like a slight overlap there. The whole body vibration test by Ruck, that one, that was when they measured 3 regions of the femoral region, and that was a small sample size of 17 cerebral palsy children, which was the average age of 8, so pre-pubertal. And they chose the result, we chose the result region for 1. And that was because the control and the intervention group at that time was at the same baseline, which was 0.60 grams per centimeter. But even with that study, using the vibration map, there was, the post-intervention measures was 0.03 with a range of 0.03 with 0 to 0.99. Now that p-value was 0.11, which wasn't statistically significant, but it did show that there was bone mineral growth for those persons using the vibration map for cerebral palsy children. And we also think that part of the reason why it wasn't statistically significant was because the wide range of values of the children, as well as the small sample size. So in summary, the overall, there was an increase in the femoral neck bone of the bone density for the jumping and weight bearing using jumping and weight bearing exercise in children. So using a pre and a post design, most studies had clear delineation between the bone growth and the change, and that was statistically significant using the 95% confidence interval. So with Thunder, like I told you before, they did their study, and there was decreased effectiveness over time with their post-intervention at the femoral neck versus the total hip. Total hip was a little bit better, but that was over a 3-year period. Ruck, their study, also using the standard vibration for cerebral palsy children, that was a pilot study, and it was a small sample size, but it also resulted in increased bone mineral density, even though it wasn't statistically significant. So the strength of the study is, since our study used randomization, it minimized collection bias, and it balances the groups in terms of various known and unknown confounding and prognostic variables. Some studies were able to achieve blinding of the participants by separating the schools and the exercise group from the control group. Within the schools, they were also separated the control group from the exercise group, because what they would do was shift the time frame so that those children would not. For the studies that only reported the pre and post intervention values, we were able to use this strata MP14 to calculate the t-test mean difference between the control and the intervention group. And we did show that the p-value and whether or not they were statistically significant. Another strength is that the majority of the studies implemented the gold standard for measuring bone mineral density of the femoral neck, and they used that DEXA scan for monitoring changes in bone mineral density over time. And the last is that they also reduced for confounded variables using the Tanner maturity criteria, and that is assessed that way in order to keep all the children in the same comparison group. The weakness of this study: the majority of the studies were unclear about their assessment of randomization, blinding, and concealment. This could cause a certain bias, which occurs when results or conclusions of the trial are systematically distorted by knowledge of which intervention each participant had received. Another limitation is that the majority of the studies combine male and female children, and the results, whereas we all know that males have the tendency, especially after the age of 16, to have faster bone mineral growth, and that could have distorted some of the results. So we also found a couple studies that, well, at least this one had contributed our findings. So this was from the pediatric journal that was from 2007. And what they said was that childhood bone mass acquisition and peak bone mass may not be as important in the determination of bone mass in later adulthood, according to this author, Yappy and Back. What they said was that bone mass acquisition during childhood would only have like a transient effect, and that ultimately, after the exercise was done, that your bones would just go back to the regular set point. But and they also had like animal studies and clinical studies that did show that indicates that the early bone mass acquisition does not persist. So they're thinking that it's not going to be any kind of distant, you're not going to be able to keep your bone mineral density for that long period of time if you don't continue to exercise. The other thing was that we found a study that did agree with our findings, and that was from a Scandinavian study that also did a longitudinal study from Thomas, and they said that in their overall study, bone mineral density increased significantly with a p-value less than 0.05 in all sites and in both sets, and that their mean annual percentage increase for the femoral neck, total hip, and total body aerial bone mineral density. And you'll see here that for the girls it was 0.3, 0.5, and 0.8, but of course for the boys it was a little bit higher, 1.5, 1.1, and 2. And so it did also have a p-value that was less than 0.05, which was statistically significant. So we have a couple of questions and suggestions for clinicians in the future. So how long should children exercise to maintain this bone bank, especially at the peak? And according to Gunther, in his longitudinal study that collected bone mineral measurements over an 8-year period, but remember I told you before that the intervention was only for a 7-month duration, it did show that they still had increased bone mineral density, but it was for a short period of time, only 3 years. While increasing childhood obesity and the increase of pediatric fractures that are associated with decreased bone mineral density one of our suggestions is that you could just have these simple jumping exercises or like a vibration mat. And it should be and needs to be further investigated, which could also lead to like school policy changes for physical activity curriculum with children who are either attending school or using online. So the next steps for research should be that the majority of these studies were school-based. And with the advent of COVID-19 and the increased use of this online school at home, using the simple exercise, jumping exercise, can decrease children's sedentary lifestyle and childhood obesity, along with increasing bone health. Children who were from a low socioeconomic household and that don't have access to exercise equipment, this should not be a barrier. Because all you can do is just use a simple box and you can increase your bone mineral density or use a jump rope. So in conclusion, childhood fractures represent a significant portion of pediatric emergency department visits in North America and Australia. So the impact of physical activity on bone mineral density in children aged 0 to 18 was evaluated in our study. And we found a positive association between adding physical exercise to children's daily routine in school or at home. And it was observed that there was an increase in their overall bone mineral density. The sample for this study also included children from other comorbidities such as obesity and cerebral palsy. And for such children, the inclusion of physical activity like jumping or using a vibration mat should be a part of the school's physical activity curriculum. So this was actually a sample from the school in the U.S. school from Oregon. And these were the two equipment that was used for the cerebral palsy article. One is the vibration mat, and this one is the standing side to side that they use. References? And I'd like to thank you for your time and attention. And I'd like to thank you for the early time that you answer this study.
I have a question for the audience. Yes, ma'am. Two questions. Please ask it.
Well, yes, thank you for this great presentation. It indicates, different other studies that we have to start young and a young age. And the question is always, if you start something at a young age, does it persist? Can you see tracking going to adolescence and adulthood? I've got two questions. First one, has there been any information on diet? Because the diet can influence your results in two directions. First, if there is any diet that might increase the bone density, it might be associated also with the amount of exercise with people who more physical activity. They tend to have a higher food consumption, so that could be a confounding. The other one is especially one part of the diet is the soda consumption, because soda consumption has been proven to work the other way. So even it could reduce bone density. So I don't know whether if any of those studies have that information included, and if there is no, or what influence it could have. But sometimes that information is not there. So in that case, it could be a advice for. But I don't know whether this information is there.
Okay, so for the 10 studies, all of the articles, they did do a dietary questionnaire at the beginning. They made sure that confounding bias was definitely, that there wasn't any discrepancies in their diet as far as calcium intake, vitamin D intake, and if they were on any medication that would influence their bone density. So they made sure that they excluded those persons. And for most of the children, they were all healthy, so they didn't really have any extra medications that they were taking. And if they did, some of them, they were excluded. So they did do a questionnaire. The thing is that there were some articles, they did talk about what their calcium intake was, and they did note it. But because of the fact that what we were looking at was basically exercise pre and post with intervention, because there's a boatload of information out there for dietary, but not that many, as you see, from 261, and that was worldwide. That was worldwide, that 261. There weren't that many that dealt with just exercise alone changing bone density, because all of the exercise, especially the jumping, is weight bearing. They even made sure that when they were jumping, that they were placing their feet in the right place, and that they didn't have shoes and socks on, so that there wouldn't be any kind of alteration in the way how the children jump off.
Well, we don't think, I think the clarifies that most of the research we have a life history data at the beginning of intervention.
Yes.
Also, there were differences between the physical exercise and control.
Right, so they also looked into they did all their measurements beforehand, and they made sure that all the kids across when they tried finding them, and make sure that they were all in the same. There was one of the studies, and I think, they even wanted to look to see that was on the cake. They wanted to look to see whether or not there was any differences between not only just the gender, because that's out there, but race. So there was out there. They wanted to see whether or not there was the difference between Asian population versus the Caucasian population, because they said there was more information about the Caucasian population. So they looked at all of that, and they really made sure to just bring it all the way down to just. And that's why
Thank you. Excellent.
So very nice study, and questions are only to encourage you and learn, for us to learn. I wanted to learn. Why did you mention 0 to 18 wherever you mentioned age? What is the meaning of the subject having 0 years? Who is the youngest person in your study? So that's one question. Oh, there's two. Second question, very close to what Dr. Kelly asked. I was thinking about vitamin D and diet, but when you exercise indoors, right, you still have vitamin D deficiency. It's not contact, right? And it is a disease of rich kids, mind you. Rich kids have vitamin D deficiency. It's not socio-economic. So if studies have not considered that, we should, because bone density depends on our movement in the sun. So it depends on which country I'm living.
Yes.
If I'm born in Antarctica, I will not have normal bone density. How much ever I exercise, whatever I eat. Okay, that has to be considered, especially your study is international. Okay, that is one. The second thing is about the age. Suppose you change your inclusion criteria to up to 16, bone density does not matter, because at puberty, you mentioned in your limitations. Yes. You mentioned it, but still I want to put forward a question. Would yours change if you change the age to 16? They will definitely change, because density is age dependent.
Yes.
You are including 0 to 18, and I am really waiting to hear what does that 0 mean.
Okay. So that was a huge debate in between the office about using 0, because we use pediatric children. And so when you're doing your people evaluation of the population, it starts, pediatric children is considered from 0 to 18. But I have a problem here. But the issue with that is that when you look at all the studies, our age range was between 3 and 18. And the only reason why 18 was really added on it, because when they were doing all these studies, these were prepubescent children. So, and there was only one study that kind of went to peripuberty right before, and if their Tanner stage jumped to like 4 or 5, then they took them out to study. So it was really school age, elementary school children, so I kind of answered your question, they still have good phone. What was the other? Oh, and then the other question was, is that, because we did US, well, here's the thing, we had some that had for Georgia, right? As opposed to the majority of ours was out west, even in California. What ended up happening was because of, we had to let them go because they didn't really focus fully on just exercise, they did the whole gamut. Calcium, vitamin D, and exercises, it was all together and there wasn't a clear delineation about loneliness.
You want to make sure that you work with definition of authority. You move from thing to yeah, sometimes you don't break it through, so you need to go into
And that's basically what we ended up with, just broadening our population so that we could get the final 10 articles. And it was kind of like a stretch to, in order to get that.
The results will be different.
Yeah.
It's still a ranking, the density.
Yes. And the other thing is that there's a lot more studies based on adolescents too, for exercising, supplementing, and all that nutrition, and said they have that information in there. Just when you start talking about the increase of time, how long does that actually last, and really we need to actually start it. That's why we
Excellent presentation. Thank you very much. I would like to add one more thing regarding the benefits of physical exercise. It not only increases the bone mineral density, the physical exercise, in this case, more of weight bearing exercise and muscle stretching exercise, increases your HDL, high cholesterol level, which is a negative risk factor for the students in activities. It increases the negative factor for pulmonary heart disease. I used to tell the students, please remember, one is physical exercise, second is estrogen. That itself explains why the incidence of ischemic heart disease and myocardial infarction is rather uncommon, childbearing experience because of estrogen. It not only increases your HDL, it also suppresses the osteoblast activity, but in other words, interleukin 1. So this increases your HDL, which is beneficial. Third is what was student is. Third is, which is unpalatable to say, ethanol. Ethyl alcohol also in moderation increases your HDL. Another important thing I would like to tell our others who are studying seriously for years and only, they should go to regular exercise and increases the testosterone level also. So please remember that. You lots of benefits of physical exercise. Your topic is jumping exercise. Here it is more of weight bearing and muscle stretching exercise. Thank you.
All right, thank you, Diane and Lisa. Next on up, we have Abinaya Adebona, an MD2 student here at Avalon. Abinaya has completed her B.Pharm from Paula BC Ona Banjo University in Nigeria, along with her Master's of Science from the University of Lagos. She has over 5 years of experience as a hospital pharmacist and was a lecturer at the Federal University in Nigeria in the Department of Pharmacy and Pharmaceutical Technology for 3 years.
Anna is also a member of the International Pharmaceutical Federal Association in Geneva. She also spends her time as part of the Pharmaceutical Society of Nigeria, along with the Association of Lady Pharmacists of Nigeria. Furthermore, she has 4 published publications. So without further ado, I would like to welcome Nigeria's finest Abinaya Adebona.
My name is Anna. I'll be standing on the existing protocols. I'll be talking this afternoon on the development and characterization of collagen-based nanofibrous scaffolds containing C-phosphodiazine and aspartatus ruderius extract for potential wound healing applications. Now, the topic itself seems very complicated, and a lot of the audience will be like, oh, this topic is too complicated. But now let me break it down. We actually, in this study, we try to develop a material. Take, for instance, a gauze that is used to take care of chronic wounds. That is what we try to develop here. But then we already have gauze. We are looking at something that has a nano diameter that could actually aid absorption, and at the same time that will have a large surface area, that will have a good porosity, and then that will encourage cell adhesion and invariably encourage wound healing. And there are other other products that are available in the market. So what we did was, to some of these samples, we tried to add some of those available materials in the market. Like, for instance, we have available 1% silver sulfadiazine in the market, and so we try to add that. We also try to have some samples that do not have some silver sulfadiazine, and so we also try to incorporate some that has this plant extract, that is Aspergillus ruderius, is a plant extract that is indigenous to South Africa. So we try to do that, and we have about 4 different samples. We have about 2 of them that contains everything, then we have about 1 that does not contain that contains the plant extract but not the silver sulfadiazine. Then we have a control which contains only polylactic acid, that is the polymer alone to serve as a control. That is exactly what we did. And actually the aim is, let's see if we can actually have something. Okay, let's see if we can have something that will be better for you. So this is an outline where we'll talk. I'll be giving a brief introduction of what chronic wound is all about, the statement of the problem, research goal of abstracts, literature review, sorry about that. Literature review, methodology, discussion, conclusion, and then my references. Now, what is exactly chronic wounds? Chronic wounds are wounds that refuse to heal in an orderly set of stages and within predictable time frame. We are actually talking about wounds that refuse to heal within 3 months is considered to be chronic wound. And then chronic wound patients frequently suffer from highly breeded diseases such as diabetes and obesity. And this comes actually because this chronic wound is often associated with these diseases. Sometimes these diseases seem to overshadow the significance of chronic wounds. Some people don't even see it as a major health challenge. Let's take an example of this NIH research portfolio that was done some time ago. It is actually directed at providing access to estimate funding for various diseases. Unfortunately, chronic wound was not included in the list, and that is to show that some do not consider it as a burden. But in essence, all the audience will agree with me that chronic wound is actually a burden both to the health community and to the population at large. For instance, in the United States, chronic wound affects about 6.5 billion patients. Then an excess of 25 billion is being spent annually to care for chronic wounds. Of course, this burden continues to grow every day, increasing the healthcare costs. We also have an aging population and a sharp rise in the incidence of diabetes and obesity annually. And the annual projection for this market is being projected to reach 15.3 billion by 2030. And that's quite a lot. Now, if we look at Nigeria, where this study, because we also have to consider the area where this research was carried out, what actually is the figure that we have in Nigeria? There is a study that was done by Ayodele et al. Using the University College Hospital in Ibadan, one of the biggest hospitals in Nigeria. And a study was conducted in the Department of Plastic, Reconstructive and Anesthetic Surgery. And it was discovered that each month, 45 patients with 78 wounds representing approximately 11% of patients that are saying that department. You will agree with me that that is quite huge. And the age ranges from 3 months to 8 months with a median age of 48 years. And the ratio between male and female is 1.6 to 1. And the duration of wound healing ranges from the median wound healing of it's about 10 weeks. And so they were able to cover diabetic wound, precious ulcer wounds, post-infection ulcers, post-traumatic ulcers, then malignant ulcers. And of course, there is no doubt that with this figure, you will agree with me that these patients that we're even talking about, for instance, these patients in Nigeria would have visited some traditional healers either after or before coming to the hospital. And this is usually either due to ignorance or maybe sometimes they believe that they are not getting the desired results. And most importantly, the availability of the treatment options, which is actually what we intend to address in this study. So there is therefore a need for an urgent and immediate need for novel strategies and techniques that can both prevent, treat, and at the same time be affordable in order to prevent the complications that are resulting from chronic wounds. And so tissue engineering has, however, offered this hope. And this is exactly what diabetic wounds looks, diabetic wound ulcers, we have the normal skin and then the ulcerative skin. Then what are the causes of chronic wound? I won't elaborate much on that because the audience is well familiar with this. We have serious bacterial burden, repeated trauma resulting in self-proliferation. We have diabetes, increase in sugar level. We have which causes imbalances between the production and degeneration of collagen molecules. And so to effectively manage this wound, there is need for us to understand normal wound healing processes is very key. And then to put in place an effective, healthy, physical, and biochemical environment in order to heal wound healing. Of course, the MD2 student will perfectly relate to this diagram about the wound healing processes, the primary and secondary homeostasis, the coagulation. And of course, an honorable professor, Professor Praveen, has actually done justice to this because it's very good at that. So you will agree with me that to achieve proper wound healing, we need to take cognizance of these two. Now, what are the current trends in the present treatment of chronic wound? We have them listed here, such as hydrogel, elastic bandages, gauze, and non-wound materials. We have antimicrobial agents, we have composites, honey, and then maybe surgical treatment at times. Okay, then what is the, although I have briefly mentioned some statements of problem, but then I'll just be going over quickly some that I didn't cover, and that is the diagnostic uncertainty that is associated with the materials that are currently used in wound. Okay. Then we have reoccurrence of the wound, we have inability to deliver the drug directly to the site of action, we have sometimes poor absorption from these materials that are currently used, and some of these material options also exposes patients to further risk. And so, although there have been advances in multidisciplinary wound care, and this has resulted in improved clinical outcome, but the economic and social impact of wound healing still continue to grow. And as such, there is need to, like I said earlier, develop a good material that will be cost effective, that will be affordable to the general population. Now, what is the rationale of the study is what I have mentioned in order to actually develop an electrospun fiber. Okay, so to develop an electrospun fiber that will be able to take care of chronic wounds. Now, the literature review on the electrospun fibers, we have Hugh et al. develop a multi-layered co-electrospun scaffold that is containing silver sulfadiazine as a prophylactic against osteomyelitis, which was seen to have greater potential in management of bone infection. And we also have Lee and Bay, which they evaluated the inflammatory effect of aspartame and notopagine. These aspartame and notopagine are actually the active ingredients that are present in Aspalathus lunaris plant extract. And Pingy et al. Too, they showed that the pro-inflammatory nature of fermented bromos has been therapeutic value for wounds characterized with a delayed initial inflammatory phase, as shown in chronic wounds. And so this study seeks to fabricate nanofiber scaffold from biodegradable material, and in this instance, we are using polylactic acid. We are incorporating robust extract that has been postulated to have inherent antibacterial and wound healing activity using polymer. We also seek to fabricate we also seek to incorporate silver sulfadiazine in some of these things. We'll go over the methods. I would just want us to watch we've been talking about electrospinning, electrospun material. Some of us may not have heard, and so the word may seem very big. How do we produce this? Please let us watch a very short video on how electrospinning is done. Thank you. That is exactly the white material you are seeing on that foil is the that is how it is being removed. That is the nanofiber. And so that is exactly how the nanofiber are being prepared. And it is after the fabrication of this nanofiber that we went ahead to then incorporate some other things that we have to incorporate. Thank you, Dr. Anthony. Microscopy, and this is to determine the surface morphology of the electrospun fibers. And then again, we also did the porosity. The porosity of the scaffold will actually determine the adhesion of the cells to it. And so we use the liquid displacement method with while we use ethanol as the displacement liquid. We also determine the tensile strength of the material. Also, we did something that is called the differential scanning and colorimetry, which is actually an analysis of any possible polymer interaction, and the thermal transitions were recorded. We also did something that is called FTIR, and we will do that in order to characterize the absorption points of the nanofibers, and that will actually tell us if there is any interaction between what is within the polymer and the materials that is actually added. We actually, for some, for the samples that had silver, we also tried to use mass spectroscopy in order to determine the amount of silver that was incorporated. Maybe we actually have that amount or not. Then after that, we also did the antibacterial activity assessment, where we use typical clinical isolates of Pseudomonas aeruginosa, Staphylococcus aureus. We use methicillin resistant Staphylococcus. We also use E. coli. And so we determined it using the disk dilution method, using 150 millimeter diameter below heating 8 plates. Then we use the gentamicin plate as a control. An antibiotic disc of gentamicin was placed at the center of the plate so as to serve as a control. And then it was incubated at 35 degrees for 24 hours. And then zones of inhibition were actually we tried to visualize zones of inhibition. We also tried to do something that is called the MTT assay in order to determine if these nanofibers are actually toxic to the skin or not, because it must not be toxic to the skin so that we can achieve the desired effect that we actually want. And so, going back to the results. Yes, this is actually what the STM looks like that I talked about in order to determine the morphology. We discovered that after performing this experiment, the fiber diameters of the scaffolds that were generated, they were slightly larger than that of the native extracellular matrix. But however, the variability of the scaffold would still enable infiltrating cells to undergo cellular attachment and then facilitate wound healing. And the fibers have smaller nano diameters than the conventional wound dressing materials that we have. Now we use the polymer silver dressing material, which some of us are familiar with, as the control in order to compare. Then from here we can also see that, for instance, in the first one, there's something that appears to be swollen. That is actually what we call beads and junctions, and they could sometimes be due to agglomeration and random dispersion of hydrophilic constituents. Then this is the first one is what we call the FTIR, and the second one beside it is what we have for the differential scanning electrometry. If you look at the FTIR, for instance, sample A, B, and C, which is represented as sample EF1, EF2, and EF3, you can see that they are very similar. And so if there are differences in the peak, we have, for instance, for sample A, the peak was we have for sample A, we have it at 1,751, whereas the normal one we have down here, which is D, the D is the control because it's just the polymer without any addition. The polymer is 1,748 centimeters, whereas the other ones we have one for A, we have 1,751, B, we have 1,752, and for the last one we have 1,748. And so, although there are little distant peak of little distant peak that we saw, but then the distant peaks could be as a result of some polyphenol which that is present in the Aspergillus fumariis. Then again, for this we also say that sample E and sample G is the same thing. There is no interaction as a result of incorporation of those materials. Then we did the study of the silver ion to determine the amount of silver. The silver ion in A incorporated in 1%, and we see that the addition of other materials did not affect the release of the silver. Sample 3 and 4 did not have the silver and so was not released, but sample 1 and 2 has the silver, and so it was adequately released, and this was done using the mass electrospectroscopy. And we also try to do the cytotoxicity studies to see if there is any keratinocyte proliferation. From day 1, we can see that there are proliferations, and day 5, we can see. We also use keratinocytes alone without adding anything as a wall, and we can see that they are comparable with the control. Even the one at the middle, which is sample 3, has better than even the control itself as a result of the materials, other substances that were added to it. Then we also have the antimicrobial activity, where we have the organisms seated in those. We have E. coli for the first one, we have Staph aureus for the second one, then methicillin resistance, and then we try to also compare it with the one for the gentamicin disc and for the polymer silver dressing, and we discovered that a lot of them did, for instance, sample 1 and sample 2 did excellently well. Then we also use we also, like earlier, the Aspergillus rhinoides is known to have an antioxidant activity. So we try to compare the antioxidant activity of that with the polymer silver dressing available in the market, and also with the vitamin C itself. And so the last line down there is for the polymer silver dressing. Then we can see the influence of the Aspergillus rhinoides, because we have the scavenging of the DPP activities of the A. linearis that shows that has a better scavenging activity than the polymer silver dressing. And the scavenging activity is actually very important in wound healing. So we can then conclude that the addition of collagen and the silver sulfadiazine A. linearis to the PLS solution prior to spinning helps to elevate the hydrophobic nature of the materials. So keratinocytes were able to grow and proliferate excellently on this scaffold, especially sample 1, 2, and 3. And all the scaffolds provided substrates, a favorable substrate for the keratinocytes. Then the fabricated scaffolds play a role like that of the extracellular matrix, stimulated by providing a high surface area to volume ratio, which is actually critical for cell attachment and proliferation in order to aid wound healing. And evaluating the antimicrobial activity, we saw that in many of the samples inhibited the microorganisms, with the sample 1 having the largest zone of inhibition as a result of the silver sulfadiazine higher concentration that was in that. Also, we saw that in sample 1 and 2. So we can say that the scaffolds that has been developed provided favorable substrates for cell attachment and proliferation. It has a good scavenging activity and can therefore be used as a potential wound healing material. And these are my references. Thank you.
That was a very good presentation. So, in my past life, I used to do healing, wound care. So, one of my questions that I have for you, as far as the experiment that you have, are they going to do any like head-to-head comparisons with evidence-based against any of the other wound healing versus any other wound types of healing? Is that going to be on the agenda for the next time? Are they going to do anything like that in comparison? Because, you know, we always talk about evidence-based medicine comparison to other ones. What makes yours that much special than anybody else's? So that's my next question.
Thank you very much. I was actually going to do that for my PhD before I came to Avalon. You are very correct. That's the step for that from the service. And I was already working on that to do that comparison before coming to Avalon. Thank you.
Excellent presentation. Thank you very much for that. I would like to know your opinion about zinc as a place wound healing. And also, zinc has been used extensively nowadays for the treatment of COVID-19 nowadays. Especially the deficiency of zinc causes of anosmia, and loss of taste. So it plays a very important role. In this case, which I talked about green. Even at the bullying, that was the pre-mortem of the wound, that is collagen plus converted to collagen 1 by metalloprotease plus zinc as a cofactor. What is your opinion about that in the wounds?
What is the disadvantage of your method? No disadvantage. Only advantages.
Okay, like I said earlier, for instance, for the limitations, that would be one of the limitations I talking about, right? Yes. Then one of the limitations that I earlier pointed out is that some of the nanofibers were slightly more than the diameter of the extracellular matrix, because maybe sometimes due to the maybe the components of the aspalat urinaris, which we actually intend to look at how that can be worked on. However, we were able to achieve the results that we wanted, but there is room for improvement in the next studies.
Thank you. Actually, one of the two important symptoms in COVID-19 nowadays is actually there's a strong indicator as a symptomatology in COVID-19 is loss of taste and loss of smell. This also occurs in zinc deficiency. If you take COVID-19 patients, they are more actually zinc deficient people are more complicated, infected. Also complications of COVID is very serious also in that case. So we got to think about the importance of zinc as an important material, also as a wound relief, also unique aspects of the reaction. Thank you.
I think.
Hello. Thank you very much. It's a very relevant study. I just want to ask a question or two. There are quite a number of components that were incorporated in your fund, some of which are antibiotics. Were you able to ascertain which components actually cause the healing? Is it possible that the healing is produced by the antibiotics? And the other question is there a buffer chance that since this material is a foreign body, that it can bring infection into the body?
Thank you, Doctor. Well, maybe I'll just quickly say that Doctor, this is not me doing initial action. So I cannot bring the infection from outside. So actually, for your first question, you were, if not for the time, I think I would have explained the result better. We available at the market, we have the silver sulfadiazine as 1%, and so there is a particular one which is sample 3 that does not have silver sulfadiazine, and we what we discovered was that that one was also comparable or even more during self-proliferation, because what we discovered was that the silver sulfadiazine for sample 1 and sample 2 that it was incorporated into, it actually a kind of reduced part of some of the self-proliferation, unlike the one that has the Aspalathus linearis plant extract. That's what we discovered from the study. And then we're talking about, we are actually looking at developing something that will be better than the present wound healing material that we have right now, so that when we incorporate these items with the tiny or nano diameter, then we are aiming to produce something that is biodegradable, unlike the present wound healing dressing material.
Thank you very much.
All right, thank you very much, Avalon. We will be discussing this research on COVID-19 and its relations to pregnancy.
Please give Dr. Sarah one more.
And we will also ask, if you have any questions, please refrain from asking them until the end of our presentation today. Thank you.
Okay, bye.
Hello, everyone. Welcome. First thing, I want to thank research department in the university, along with ACE, which is doing an amazing job for organizing these events, which is amazing. We want to talk a little bit quickly about the topic of the effect of the COVID-19 in pregnancy. Risk of infection in pregnancy. So we have a lot of questions nowadays on COVID, and basically pregnancy is this kind of like a huge topic here, but I'm going to make it simple. When you look to the risk of infections in pregnant women, pregnancy usually does not increase the risk to contract the infection than the general population. So till now, we don't have evidence that telling that pregnancy may have higher risk compared to the normal population, which is somehow good news on that point. But pregnancy after, at the same time, the body's immune system and can cause more severe symptoms with COVID, if you look at that angle. So we have a study that have been done in Satan area, and those studies till now they never improved that the pregnancy they have differences in fact compared to others. I'm going to talk about the most common study that we have recently. So when you talk about the effect of the COVID-19 in pregnancy treatment, as I say, we have the 40 cases that show that the pregnancy usually they can have mild symptoms of pneumonia, it's not even severe symptoms. But the only problem that is patients that they are immunocompromised patients or patients that they have no case of chronic issues like hypertension or diabetes, so they can have more symptoms compared to the normal patients. Yeah, in other types of the coronavirus, for example, SARS or this type, the risk of the mother appears to increase, particularly during the last trimester of pregnancy compared to the first and second trimester. Same thing that some researchers they consider that in coronavirus that the pregnant woman she will have more impact when she arrives in the third trimester compared to the first and second trimester. There are cases of one of the preterm birth, also it happened in the certain area, COVID, but really we are not clear about why it really is due to COVID or due to other things that we don't figure out yet. And you know that we still have a lot of study going on that area also. The coronavirus epidemic increases the risk of prenatal anxiety and depression, and this is kind of a huge topic, especially when you think about the psychological effect of COVID in pregnancy. And I think it's quite like important because we're going to feel it the next few years because till now no one pay attention for what is the psychological effect of COVID during that period. Because we think till now a lot of people, even including pregnant women,
they have assistance from their own government, but after a while, I think we're going to face some psychological and issues related to that. It will be very prominent. I think we need to be ready for that point as well. Same thing also when you think about pregnancy, definitely we're going to have to tell you on that very soon. We have a small study that done with 9 pregnant women in Wuhan, the same city that the COVID started, China, and confirmed that COVID-19 found no evidence of virus in their breast milk or cord blood or amniotic fluid, which is the good news. So it tells us that, unlikely that advisable for us to stop breastfeeding for patients that no case for COVID at the same time, because we don't have any evidence that the virus could be in the milk or things like that. The other study that from like 43 pregnant women in New York confirmed COVID-19 published in American Journal. Also, they confirmed that unlikely to find COVID or SARS or NH1 in the they found that confirmed COVID-19 published in the American Journal. They confirmed that unlike SARS and H1N1, pregnant woman does not seem to experience more severe illness from the coronavirus compared to general population. We don't have any evidence also compared to that woman. They have more symptoms when we look for the other subtype like SARS or H1N1, which is called that the bird. It's also very common contact. Other study published later in the New England Journal of Medicine looked at testing data from the pregnant woman who delivered between March 22 and after. This study also showed that out of the 215 patients, we have around 88% of women who tested positive for COVID did not show any symptoms. Did not show any symptoms. Again, we don't have any evidence that the COVID may have more symptoms compared to others when you look for the population. At the same time, you have to be precautions for other pregnancy should be done. Social distancing at the same time is important for them. Avoid unnecessary visits outside of the home. Even now, some physicians start talking about this any way that you can minimize the prenatal visit, for example, regular prenatal visit. Some physicians they start talking about why we don't eliminate those visits instead of regular visit before. So they start thinking about eliminating that one because it's important also to think about if you have too much prenatal visit, you have more chance for getting virus rather than yes. So also there is some countries they start also thinking about that. Practice hand hygiene, respiratory hygiene, all of it is very important part of that, especially for pregnant ladies. Avoiding touching face, work from home, so many policies, and there is study that can be implemented so it will reduce the risk of infection in pregnancy. When you look at the routine antenatal care visits, basically it's work for pregnancy consultation on phone and videos more necessary than direct outpatient clinic, and also come alone or keep the number of the people less. It's very important when the patients go to the clinic for normal follow-up. Along with that, follow hand hygiene, wear masks, gloves, all those kinds of like normal things that we used to do to decrease the infection, which is also very important for pregnant lady in the prenatal period. For the COVID pregnancy, pregnant woman who has acute respiratory illness is one of the following criteria is indication for testing. Because maybe sometimes we have to ask questions, is there any woman have pregnancy? Should be tested or not? But we have criteria, this is most likely from the Ministry of Health of India, they have scientific criteria, they say, oh, for example, if the patient has a history of travel abroad in the last 15 weeks, this is indication for test. It's kind of like they put different criteria here. For example, if the patient she is a healthcare worker, also is indication for testing. So, pregnant woman who is presently with symptoms could be tested between 5 to 14 days of coming in the direct and high risk contact individual. So it's kind of like became guidelines for the government. And also it's good to implement those ideas so we can make sure that these recognize the case earlier. The cause of COVID-19 for the pregnancy, most women are mild and moderate symptoms. We don't have severe symptoms. Only those patients that they have immunocompromised issues. Women with severe disease are those who have associated with, as I said, hypertension, diabetes, or the muscle density higher, so they have more severe symptoms compared to others. So this is also kind of like normal. You can see that even in normal people, so there's no difference between that and normal calculations, which is quite good news in that area. So at the present, there is one published case of a woman with severe COVID-19 at 34 weeks in ICU with multiple organ dysfunction, which is not common, but it can lead to multiple organ dysfunction, stress syndromes, and all those kinds of things can happen, especially if the patient is immunocompromised. We have some data from Australia and have identified also that there are significant increase in critical illness in later pregnancy compared with early pregnancy. When it comes to the complications, typically we have few complications that we observe during COVID for pregnancy. For example, preterm labor, very common, especially before 37 weeks. Preeclampsia, stillbirth, some numbers have been reported. So it's kind of like, it's not kind of big issue to worry about, but you have to understand that also we have some complications, especially with those patients, as I said, immunocompromised. When you come to the fetus side, is it really any effect of COVID for fetus? That's the question. From all very recent evidence suggests that the virus may be transmitted vertically. Maybe. When I say maybe, that means they don't have evidence for that. They say maybe it can happen, right? Because of that, also we have to understand that even though we think that it can happens, but we don't have evidence, no evidence that showing COVID-19 can be found in the lymph fluid or we have any transmissions through the cord blood or things like that, which is still going on. But there's still some studies they think that we have some room for better transmission, but there is no room for that. Currently, there are very good data on COVID-19. Still, a lot of research should be done on that. When it comes to delivery, the delivery should be normal. There's no indication for cesarean section for patients with COVID. So, as I said, you don't have any indication for that. Since you talk about, you don't need to worry for blood. But anyway, you have to understand this. We have possibilities for benefit of these need to be weak against the. For example, if you have a patient that thinks that it's better for this patient to go to the normal vaginal delivery or cesarean section, then you have to outweigh the risk with the benefit to see which one is the best for the patient. So we don't have any guidelines for saying that it's better to do cesarean section for patients have COVID. So kind of like we normal patients, as I say. Mode of delivery, definitely mode of birth should not be influenced by any present COVID, unless the woman has respiratory conditions or things like that. Then at that point, you can think about cesarean section. So it's kind of like only if certain type of patient have some severe symptoms. Precaution of transmission prevention. Patients should decide when you look for the what type of patient that, because sometimes maybe some of us, it's important for us to isolate the patient that she has COVID if she's pregnant. The question for the answer for that, no, we don't have any evidence that saying that it's important to put the patient in negative pressure shoe. Negative pressure those kind of like specific rule that we use for isolation, especially for hypothalamic type of disease. We don't have any evidence for that, so we have to treat them as usual. So we don't have any things for studies saying that they should be isolated. That is still going on. Same thing here, it's nothing changed. We have to take care during labor. Maternal vital nutrients should be done standardly. Oxygen therapy should be done if needed, especially if the patient is stress syndrome. Early interventions with oxygen and all those things should be done if that's needed, especially for those patients who have immunocompromised patients. All care should be taken to reduce need of blood transfusions, because as I said again, we don't have evidence for it, but some studies still they think that we have, so it's kind of like we have to take care of our avoid delay, code crampings, especially if the oil quality physician. They also recognize that, or at least they advise the physician to do that. This is kind of like important things that to reduce the infection between treatments as well. When it comes to anesthesia, if you do that, it's the best. Okay? Whether that general anesthesia, although we don't like general anesthesia for treatment, but if you do that, they found that, especially for COVID patients, is the best compared to general anesthesia. So they encourage also to do that, necessary, especially if the patient going for the cesarean section. You have to evaluate also the infants, according to CDC guidelines. Normal monitoring, you don't have any special monitoring for the baby. It's COVID patients, so should be monitored as usual. The last one is the care should be done properly according to the lower quality of physicians. Breastfeeding, there is no indication for isolations. Again, breastfeeding that almost into HIV patients. So breastfeeding should be normal. We don't have any indication for isolation for that. Separation, there is no need, but some physicians they think that if the patient is positive, until the patient is antiviral for 3 days without use of antibiotics, it can be done. The isolation here, or if the patient has respiratory symptoms are improved on at least 2 consecutive COVID cases, especially if the patient has been bilateral swab positive at the same time, so you can see the isolation as well. It will be useful. Let me see. Okay. The last one is postnatal care should be done for baby, and that's also very important. Thank you so much.
Thank you. Today he will be discussing his research on the relationship of ACE2 receptors to COVID-19 pathophysiology. Please welcome Dr. Avalon onto the stage.
Thank you very much. We need to talk first about what is the ACE in our part 2. How is it connected to coronavirus? Before that, we need to know we have an idea about the ROS system. It is not present not only the kidney, it also present almost all organs of our body. The lungs is present, adrenals are present, GI tract is present, also the pancreas. Sometimes that in the morning we are talking about the black fungus, which is due to the fungal involvement in the ACE receptors such as pancreas. So ACE system, the ROS system is present in almost all the organs. Before that, I would like to first just mention about the normal physiology of the ROS system. ROS system actually is because of a vasoconstriction. There is intraarterial pressure of the glomerulus, for example, kidney as the ROS system in the kidney. There is decreased intraarterial pressure, it activates the vasoreceptors activates the renin acts on substrate and angiotensin protein. That is created from the synthesized and created from the liver. And then angiotensin protein is active over then angiotensin called enzyme, which is released from the pulmonary capillaries. The angiotensin is again created into angiotensin 2. What is angiotensin 2? Angiotensin already got angiotensin. So angiotensin was the intermediate product, and angiotensin 2 is the end product of the ROS system of that is present in almost all the organs. This angiotensin 2 acts on 3 types of receptors. There are AC1, AC2, AC3. Receptors are nothing but they are the angiotensin 1 enzyme, angiotensin 2 enzyme. They are more interested in these 2 enzymes. So this angiotensin 2 acts on through via the angiotensin 1 receptor on the angiotensin E1 enzymes. It is actually just got more adverse effects. Whereas angiotensin 2 also acts equally on the angiotensin converting enzyme E2 via the ACE2 receptors. Now our interest of this discussion is ACE2 receptors. These two angiotensin enzymes, 1 and 2, present in equal amount normally, that is physiologically, in the system. So angiotensin 2, what is the function of angiotensin 2 enzyme? It has got checks and balances on the angiotensin 1 enzyme. The angiotensin 1 enzyme, if it is excess, it causes adverse effects. So it is being suppressed by the angiotensin 2 enzyme. So its main action is it has got checks and balances and has got a control over it. If the angiotensin 1 goes up, which has got more adverse effects, the angiotensin 2 releases certain molecules and cuts down the larger molecule of the angiotensin 1 to angiotensin 1.7, and then it gets bound to the mast receptors, and this gets activated, and this causes angiotensin 1 effect, which is better prognosis. This is so angiotensin 2 has got a better prognosis, that is, it has got beneficial effects, whereas angiotensin 1, when it is activated, it causes osteoconstriction, inflammation, fibrosis, lung damage. This is a normal procedure. As angiotensin 2 enzyme has a checks and balance on this angiotensin 1. So these two receptors are very important for the normal hemostasis, especially in the kidney for the electrolyte and the fluid balance, and also controls the inflammation. It also controls the cellular proliferation and all those things. So let us talk about where is this angiotensin 2 receptors are present. I told you angiotensin 2 acts equally on both receptors, A1 and A3. Actually, the receptors, why are receptors on the angiotensin 1 enzyme and angiotensin 2 enzyme normal? It maintains the fine balance in normal persons. So these angiotensin receptors are situated in many epithelial tissues of the lungs, heart, blood vessels, especially the endothelial vessels, which are both arteries and veins, kidneys, which we are discussing now, and GA tract, also the enterocytes and glandular cells of the GA tract, especially the small intestine, the ileum. So it creates a positive pressure. So this angiotensin 2 plays two important roles. Number one is it has a checks and balance in the angiotensin 1 and keeps it the angiotensin 2 in a normal concentration. Now, other important factors for our discussion is angiotensin 2 receptors is being used for the coronavirus to enter the human host cells. So when coronavirus enters the angiotensin 2 receptors, so the angiotensin, this action is blunted. As a result of this, there is increased activity of the angiotensin 2, which has got adverse effects. What is the second action of this angiotensin 2? If you talk the coronavirus has got on its outer surface about 5 glycoproteins are there. One of the important glycoproteins with which the coronavirus enters the human target cells is the spike protein. This spike protein gets attached to the coronavirus, and then it penetrates the coronavirus and enters the epithelial tissues and also the cytoplasm inside. So it is got the spike protein is essential, which is present on the without this ACE2 receptor, the angiotensin, the coronavirus cannot enter the any human cell. So for the entry of coronavirus, the coronavirus should get attached to the ACE2 receptors. So as already discussed, when the ACE2 receptors are occupied with the coronavirus, it blunts its activity. As a result, the angiotensin 2 activity increases more, causing adverse reactions. These angiotensin 2 receptors more common happens like lung. Lung being the common site for the coronavirus to enter, especially the upper parts of the lung, especially the upper part of the nose, closer to the olfactory epithelium, also the sinuses. So they enter our body through the lungs. Once it enters to the lungs, it gets attached to the ACE2 receptors, and then it causes, if the lungs it enters, it causes release of phytoplankton and hormones to reserve. Once it enters, once it enters the cellular membrane releases another enzyme called cellulase protease enzyme, which cleaves the glycoprotein and the spike protein and helps the virus to move comfortably and smoothly within the cell, and it causes replication within the cell, and then it gets settled on the cytoplasm, establishing the index. So the idea is ACE2 receptor is the main source, main receptor which is occupied by the coronavirus. If there is no ACE receptor anywhere in the system, the coronavirus cannot enter. If at all it enters, it has to get attached to the ACE receptor, and then it can enter the other tissues of the body. So once the ACE2 receptor is not present and not doing exact normal function which they should do, that is, it has to cut down it has to modulate the adverse effects of angiotensin 2. There is increased amount of AC, the angiotensin 2. So this is the coronavirus having spike protein, which it gets into the ACE2 cells. The red particle is the coronavirus with the spike protein entering this is the angiotensin 2. What is the important function of this ACE2 is it breaks down the angiotensin 2 into smaller molecules. So this is here we talked about this renin glands. So this renin actually the end product of renin is angiotensin 2. Angiotensin 2 acts on both types of hormones, angiotensin 1 and angiotensin 2. They are via the receptors angiotensin 1 and angiotensin 2. Now, here the angiotensin 2 is occupied by the viruses. So it doesn't allow the ACE2 to carry out its normal function, that is, it normalizes the activity of the angiotensin 2. So as a result, there is a downregulation of the angiotensin 2 is there. As a result, there is no angiotensin 2 becomes more. Normally in our body, concentration of both angiotensin 1 and angiotensin exist in equal concentrations. Now, the angiotensin receptors now occupied by coronavirus. So there is a downregulation of the angiotensin 2. So when the amount of ACE2 is reduced, because the virus is occupying the receptor ACE2, blunting its ACE activity, individuals may be more susceptible to severe illness from COVID-19. Why? Because it works as a brake on angiotensin 2. Now the brake has been removed because this brake is occupied by the coronavirus and the spike protein. As a result, because of enough of ACE is available to facilitate viral entry, but the decrease in available ACE2, which has got checks and balance on the H2, angiotensin H2, is decreased. So there is an increased concentration of angiotensin A2, causing an increased susceptibility to inflammation, cell death, organ failure, especially in the heart and lungs. So the key factor that determines the severity of damage and infection is increased or high amount of angiotensin 2, because there is no angiotensin 2 activity because it is being occupied by coronavirus with the help of spike protein, which is present on the virus. That is the conclusion. Thank you.
Thank you very much, Dr. Avalon.
Thank you very much.
That concludes today's scheduled presentations. Please make sure to check out the abstract posters just outside the main doors.
We appreciate your commitment to your respective projects, and I look forward to hearing more about your work.
Once again, we would like to thank you for your active participation in today's research symposium.
We hope that you've enjoyed your time spent with us today, and we hope that these presentations have inspired future projects and research inquiries. I look forward to next year's presentation.
To conclude today's event, we would like to call our Dr. Sharita Bala onto the stage. Please give her a warm welcome.
Good evening, good afternoon, still, yes. Good afternoon, everybody. Thank you, both of you. There are most beautiful things in the world that cannot be seen or cannot be touched. So they say they must be only felt by the heart. That's what everyone believes, and thank you is definitely one of them. So I am most privileged to do that today. I feel flattered, honored, and privileged to get the opportunity to propose a vote of thanks for this research presentation, for research symposium. I would want to start with thank you all for your excellent work and congratulations to you all. And there is a saying that knowledge is power. I firmly believe that knowledge is power only if it is shared or applied. So today's symposium is an excellent opportunity and a great platform to all of us to learn about the latest innovations and insights that we all are, we learned today, and the key presentation, keynote speakers and presenters, and as well as the poster presentations which we are seeing today. They help us for broadening up our knowledge, and thank you so much for placing your work and sharing your expertise and knowledge with us. On behalf of the Avalon administration and faculty, I extend my gratitude and appreciation to all the keynote presenters as well as speakers, faculty, staff, students who made their gracious presence and took their valuable time from their busy schedules. The team of Avalon has contributed in many ways to turn this event a very successful symposium. Thank you all for your wonderful presentations and sharing your thoughts and creating an excellent environment. I would like to thank our research committee at Avalon. Words are not enough to thank their continuous guidance and support. I would like to appreciate and thank Dr. Lambo, our research committee chair, and all the members of the research committee for their excellence. Dr. Lambo, Dr. Robi, Dr. Ala, Dr. Kumar, Dr. Andrew, and Dr. Thadi. These are the research committee members and the student representatives for their enormous efforts and effective contribution to overseeing all the presentations and helping and guiding all the participants. I would also want to thank you and appreciate to all the keynote speakers and presenters today, Dr. Satish Archer, Dr. Katie, Dr. Jagdish, Ms. Zalika and Mangyan, as well as Dr. Diana, Edibona, Dr. Tariq and Dr. Balramia. So my special thanks to the Master of Ceremonies, Ms. Zaira and Hazim, and also my very, very special thanks to our student event coordinator, Inge Wilters, and also Steve, our SGA treasurer, and SGA vice president, Rosa, and SGA president, Brian. And all the presenters, because all the student presenters are amazing today. That's very, very impressive. Ms. Zelika, Dara Patel, Mangyan, Diana, Adibona, Tisha, and also we have the poster presenters, Ms. Rosa, Akmita, Sheetal Zain, as well as Anjali and Aziz, Sharing, and then Sheeta, for all their active participation and organization to help us. I would like to thank Dr. Amin for his outstanding effort in helping in all the technological support to make this happen. And I would also want to extend my thanks to Ms. Kimberly and Molly for all their support with their logistical help. I would want to thank and appreciate our Dean of School of Medicine, Dr. Arjun, for encouraging and guiding the committee to make this happen. I would like to thank Dr. Shokat Pate, our Chancellor, and Dr. Samir Pate, as we all are president, and all the board of directors for their encouragement and support. I agree on this, and I am extremely proud that our Avalon team has a very motivated and dedicated administration, research committee, faculty, staff, and SDA, and also all the Avalon team. And my special thanks to Dr. Katie for making sure that he's present all the day for your whole day, from your busy schedule today. Thank you so much, Dr. Katie. So I feel very, very proud and thank you for all and making this event very successful with your contribution and collaboration. Once again, I want to emphasize that we are very grateful for all the speakers on this stage, and we thank you for being with us, and it has been a very great pleasure. Congratulations once again, and wishing you all the very best for the poster presenters too. Thank you so much.